and good morning, everybody in Vietnam, and good evening, our friend in Atlanta. Today is an important day. The reason because I review the slides of the speakers, and this is the first time I see, I'm sure they did before, the Vietnamese interventional cardiologists. They accumulated a lot of experiences, a lot of data, a lot of information, and today they will tell us their experience, their data about intervention for elderly peoples in Vietnam. This is very important because in many meetings, many faculties use the data from the US or from Europe. But today, the data are from Vietnam. The cases are from Vietnam. And this is, we want to see, we can see the level of experiences, the level of sophistication of the procedure, and the level of severity of these patients. This is very important because we don't have to borrow data from the US. We don't have to borrow data from Europe. We don't have to borrow data from China, from Japan, from Korea, from other countries in Asia. Today, we show the data from Vietnam. And this is very important for us and for the Vietnamese because we can show our experiences, how to solve the problem the Vietnamese way. And this is very important. I will sit the whole session today to listen to the information from Vietnam. And thank you very much. I would like to, at this time, I would like to introduce a very special speaker, first time in our meeting, Dr. Nguyễn Thanh Huân, about the frailty in elderly patients with chronic coronary disease. He is he did his training in Japan, and I am very interested to hear, except one thing. Usually, the faculty training in Japan, they look very serious. And this is the only difference. Okay, so please, Dr. Nguyễn Thanh Huân.
Good morning, Professor. This is my great honor to present the first topic in this session. So this session titled Assessment of Frailty is on the patients with chronic coronary syndromes. So first of all, we need to know what is frailty. Frailty is not a disease. It's just a clinical process involving increased vulnerability and decreased ability to recover homeostasis following stressor events. And in the recent study on the US population, they found that physical frailty phenotype was associated with a significant risk for mortalities and development of major adverse cardiovascular outcomes, such as acute myocardial infarctions, stroke, peripheral vascular disease during 6 years of follow-up. So we can understand that frailty is an independent risk factor for cardiovascular outcomes. And how about the burden of frailty in Vietnam? According to 3 rigorous studies in Vietnam, we can see here there is a trend of increased frailty prevalence from community to geriatric clinics, with the highest prevalence being among the hospitalized on the patients. And how about the burden of frailties among the populations with chronic coronary syndrome? In the world, the prevalence of frailty in the populations is about 30%, range from 10 to 60%, depending on study population, cardiovascular disease burden, method to assess frailty, and the cutoff used to define frailties. And we have just mentioned about the method to assess frailty. Here, I show you this table. Until now, there have been 60 criteria to assess frailty. Some of them can be used in primary care, hospital, as well as long-term care facilities. But we need to know which is the gold standard to assess frailty here. Until now, Fritz frailty phenotype criteria is considered as a gold standard to evaluate, to diagnose frailty. This criteria includes 5 components of 5 criteria. Weight loss. Weight loss means unintentional weight loss, exhaustions, slowness, weakness, evaluated by dynamo methods. And the last one is low energies. If the patients who have 3 or more criteria, they are categorized as fails. Those with 1 or 2 criteria, they are categorized as fails, and no criteria, no fail. The reason is, the most important is this criteria is so complicated, and we need a dynamo method to evaluate weakness. Furthermore, it takes a long time, about 30 minutes to diagnose frailty in one patient. So in the clinical practice, in some studies, Rockwood clinical frailty scale can be used. This scale is widely used in geriatric medicines on a global level. Clinical descriptors and pictographs allow doctors to recognize and quantify frailties. For example, if your patient who are robust, active, motivated, independent for personal care, you can check here, he or she is very fit. It's very simple to diagnose frailty in clinical practice. So we move to the most important in this presentation. Why do we need to assess frailty on the patients with chronic coronary syndromes? The first is coronary artery disease is a major cause of morbidity and mortality. The second is frailty can reflect clinical events on the adults with CADs. And in the clinical practice, if we evaluate frailty, we can improve clinical decision-making by informing the predictions of benefits, subclinical interventions, or the risk of adverse reactions. So how frailty impacts on the outcome on the population with CADs? According to 2 previous studies, we can see here frailties were associated with a higher incidence of 1-year mortalities in patients after PCIs, as well as 6-month mortalities in patients after acute myocardial infarctions. So now we move to the guidelines, what they said in the guidelines. In 2018 ESC guidelines on myocardial revascularization, we can see here, in the patient with advanced age, frailties, reduced life expectancies, PCIs is more suitable for them instead of CABGs. And in the next year, in 2019 ESC guidelines for the diagnosis and management of chronic coronary syndromes, once again, we can see that the diagnosis and revascularization decisions, we choose based on symptoms, the extent of ischemia, frailties, life expectancies, and comorbidities. So we can understand that in the patients with increased frailty, the least invasive procedures is better for them. And in the same guidelines, frailty is one of factors indicating high bleeding risk in patients using anti-thrombotic drugs. So in the recent guidelines in 2020s for the management of acute coronary syndromes, we can see here once again the decision to manage on the patients should be based on many factors. For example, bleeding risk, life expectancies, quality of life, as well as frailty. However, when we look at to the right panels, we can see that it would not be unreasonable to offer optimal medical therapy plus invasive treatment for frail patients at high risk of future cardiovascular events and low risk of complications. So in conclusion, although assessment of frailty is necessary for clinical decision-making or prognosis on the patients with chronic coronary symptoms, we should remember that frailty is not a barrier for optimal medical therapy or invasive treatment in patients with coronary artery disease. Thank you so much for your attention.
According to the schedule, Dr. Vũ Hoàng Vũ will moderate the discussion of the panelists and introduce the second presentation.
In the meantime, I would like to ask Dr. Huang, that according to your study and according to your data, so what is about the longevity of Vietnamese people? So in order to, based on that, so we can discuss about the frailty and something more. Thank you.
Thank you for your questions. This is very interesting questions. According to previous study that in the world as well as in Vietnam, there are more frail women than however, surprisingly that women live longer than men. So maybe many factors influence the longevity, and not only frailty. Yes.
Thank you very much. And because the later I will present the case relating to the octogenarian. So according to your data, so the percentage of the people with frailty beyond the age of 80, so the percentage of that in Vietnam. Do you have?
According to my studies, as well as the studies in the north of Vietnam, the percentage is about 40%.
Yeah. Okay, I have a question for Dr. Gautam Kumar and Dr. Rajesh Setava. According to the presentation of Dr. Huang, assessment of frailty can improve clinical decision making when we choose the strategy for the revascularization. How about in your hospital, in your country, the application of the assessment of frailty, we can do a routine or not?
Well, as you have, thank you very much again, Professor Ho, and for that great question. You know, as you can see, you know, this frailty is a very complex issue, and it has been a very long and complex evaluation. It takes about half an hour for the evaluation to be done. Now, this generally cannot be done in the context of you know, an emergent procedure or an urgent procedure, or as in a cardiology clinic or something like that. In general, we tend to have the geriatricians involved in the care of this patient, and they are heavily involved in doing the frailty assessment. So, there is a healthcare team approach, this issue comes up when we are talking about somebody with severe aortic stenosis, and we are talking about doing the TAVR versus SAVR. I think that's where this issue really comes up. It also comes up for the CHIP complex PCIs, where we get the input of the patient's primary care geriatrician as well. Dr. Sachdev, what do you think?
I agree with Dr. Kumar. I think this plays a bigger role, I think, in TAVR versus SAVR, and as well as CABG versus PCI in geriatric patients. So somebody with, left main disease and a high frailty index, you definitely want to have that discussion with the patient as well as the family, the expectations and the risk which is involved. And likely you will opt towards doing a less invasive procedure and opt for doing a high-risk PCI with some sort of a support, either with Impala or with the intra-aortic balloon pump, rather than opting for a bypass surgery.
Okay, thank you, Dr. Rajesh Dasanova. Please, Professor Phạm Minh Hùng, you have a comment?
Hi, everybody. So I have a question for Dr. Huân, because we have a lot of the criteria or a lot of scale to assessment of the practice in elderly patient. But according to you, so do you suggest which is the most suitable to you in practical, the cane scale for in practical to you in Vietnam? Because we have some students study thesis about this, but they have found some difficulty to apply in Vietnamese patient.
Thank you so much for your question, professors. So please let me to share again my slide. And because the gold standard frailty criteria is so complicated, so in the clinical practice, we can use a Rockwood clinical fail scale. We just see and check, we just recognize and quantify frailties. It's very, very simple in the clinical practice, not only in the outpatient, but also in the patient. So in Vietnam, many studies perform this scale to diagnose frailty in clinical practice as well as in the study. Thank you so much.
Thank you, Dr. Huân, because I have a student to study assessment using the 3 scale, and she found that the Fry scale maybe have a very good correlation with the outcome of the patient. It's acute coronary syndrome, not as she said. So I only have some information about that. But the study still have a limited number of patients. So I hope in the future when we can do for the last study in whole country, we can have our own the scale for assessment of the frailty for such kind of patient. Thank you so much.
Okay, and I have one question for Dr. Nguyễn Thanh Huân. Your topic is why we need to assess frailty in older patients with chronic coronary syndrome. But recently in the ESC guideline 2018, they talk about the assessment of frailty in acute coronary syndrome, acute MI, or particularly non-STEMI. I think STEMI cannot because it's a golden time. We must very quickly, very soon to reperfusion. But non-STEMI, I think, how about your opinion? And do you apply the assessment of the frailty in your department?
Thank you so much for your professor questions. This is very important questions because in the chronic coronary syndrome disease, coronary syndrome, we have time to evaluate frailty for our patients. But in acute coronary symptoms, we need to perform intervention as soon as possible, and frailty is not a barrier for optimal medical therapy or invasive treatment in the patients. And in our department in Thống Nhất Hospital, we performed evaluations of frailties in patients with chronic coronary symptoms. Not only doctors, but also nurses. Thank you so much.
That's about the question, I think, in my opinion, because in the acute coronary syndrome or non-STEMI acute coronary syndrome, we have the strategy according to the very high risk stratification. Risk stratification, it means high risk, you must bring the patient immediately to the cath lab. But the middle and low, you can keep the patient in emergency department, and tomorrow morning you can discharge him. So in the non-STEMI or in the acute coronary syndrome, we can apply assessment of frailty in the group with the low risk. I think so. Do you agree with me?
Yes, I agree with you. Thank you so much.
Are there any question for Dr. Nguyễn Thanh Huân, the panelist? Dr. Vũ?
I'm sorry, I missed. I missed the role in after the presentation of the Dr. Thanh Huân. So I have one question for Mr. Huân. Dr. Huân is there is one trial in Nhân dân Gia Định Hospital this year. They published this year about the Vietnamese people. This trial, they have 400 patients. They have the frail scale for the patient during 6 months for 6 month recruits in this hospital. So, and they found that the frail scale is a good tool to evaluate the patient over 60 years old. So, in your opinion, in your experience, so frail scale and other score for evaluate the frailty should be which I mean that with tool to is a best one when we try to apply in clinical practice in PCI patient, mostly in PCI patient, and we in Vietnam population we use 60 is older patient. In other countries 65. So how about your opinion in this age and in the scale for Vietnamese people?
Thank you so much for your questions. The first question is risk frailty phenotype criteria is a gold standard to diagnose frailties. However, because it's very complicated and take a long time, as well as we need a dynamometer to evaluate weakness. So in the unstable patient, we cannot perform risk frailty phenotype criteria. So in the previous slides, I also mentioned that Rockwood clinical frailty scale is better for acute coronary symptoms in these situations. And the second question, in Vietnam, we define on the patient according to who, 60 years on and more. But in the Western countries, as well as in Japan, 65 years on is used to define on the person. Thank you so much.
It seems, Dr. Kumar, you have one comment, a question, Dr. Kumar.
Actually, I had exactly the same question that I wanted to get from Dr. Thanh Huân as to which scoring system he best recommends for our PCI patients. And it appears that he has answered it and said that it is probably the Rockwood scoring system. So thank you very much.
Thank you.
You're welcome.
So we still have time, 5 minutes more for discussion. So please give Dr. Huân any more question.
I have a general comment about frailty and procedures in patients who are frail in general. I think frailty applies not only just a particular population, it applies to all sort of patients. More so, we think that people who are 60, 65 and above, they are generally not, they could be, more frail because of the old age. But, somebody who is 40 years old, has multiple comorbidities, can also fall in the same sort of category. So all those things, what we are talking about, will be applicable to that particular person who is young but frail.
I'm sorry that I don't have any experience in the younger patients, and until now there haven't been any scale or criteria to diagnose frail in the younger patients. Sorry.
Yeah. So Dr. Huân, in daily practice, you will do the scale penalty for person or over 60, right? Or 65 or any age to start to do that?
Until now in our department, we just evaluate frailties for patients 60s or more, so not for younger patients. Yes.
Thank you.
You're welcome.
So and any question for Dr. Huân? Dr. Quang, do you have any question for Dr. Huân? How about in Vietnam Heart Institute? How about the faculty in daily practice in Vietnam Heart Institute? Thank you.
Thank you for your asking. So basically, we apply the same thing as Dr. Huân mentioned. We think that frailty is a really important factor, need to be accounted when we decided to which strategies for the elderly patient. We also applied the clinical frailty scale for our patient, and I think that the most important thing here is how easy when we evaluate the frailties. If you have some very good scale but difficult to calculate, and then it's no use for daily practice, because somehow it is we need to access frequently and fast before we do anything for the elderly patient. For my talk later on, I just mentioned back again about the frailties, because it is really important to consider when we choose the strategy, especially the optimal strategy for the coronary artery patient. Thank you.
Yeah, this is a great idea. Yeah, thank you so much.
So we have 2 minutes more for discussion, and if we don't have any question for the first amazing topic from Dr. Huân, maybe we move to the next speaker, right? Okay, please. And the next speaker, I would like to introduce Dr. Gautam Kumar. He will speak about the management of severity calcified coronary artery disease in the elderly patient. Please, Dr. Kumar.
Hello, are you able to see my screen?
Yeah, we see your screen clear.
Okay, beautiful. So good morning to my friends in Vietnam. It is good to see all of you again, and good evening to my colleagues in the United States. I would like to thank all of you for kindly inviting me, especially Again, all of you who are on this call, and especially my very good friend, Dr. Tak Nguyen, who has been very kind to actually help get all this going and organize this, as well as Professor Ho as well. Now, so today I will be talking about management of severely calcified coronary artery disease in the elderly patient. I have no disclosures that pertain to topics that are covered in this lecture. So first, we are going to discuss a little bit about the classification of atherosclerotic lesions. We will talk a little bit about plaque morphology and therapeutic strategy. We will discuss something about coronary calcification and the epidemiology of this, and that how this affects us in the elderly population. And then we will talk about a summary of balloon dilatation, or rather what is beyond balloon dilatation, different techniques that exist. And then I think, especially when it comes to calcification, intravascular imaging plays a very important role in these patients. And I think this devotes a little time to discuss this. And if we still have time, we will talk about a PCI case in an octogenarian patient. All right. So when you look at the classification of atherosclerotic lesions, it is interesting that when we are young, in our first 3 decades, you have these initial lesions, which are macrophages and foam cells, and subsequently these then result in fatty streaks, which are intracellular lipid accumulation. And then this progresses on to intermediate lesions that tend to occur mostly in the first 3 decades of life. And then comes mostly the disease that we deal with as interventional cardiologists, which is type 4 and below, which is the atheroma, the fibroatheroma, and the complicated lesions. And these then kind of feed off each other and progress and can be clinically silent or overt. And as we get older, next slide, we can see that the type 4 lesions can be a fibroatheroma, it can be a calcific lesion, or it can be a fibrotic lesion. And this tends to happen more in older patients. Now, this has a simple bearing on our therapeutic strategy. So if there is only one thing that we are going to carry away from this entire presentation, I recommend that this slide is the one thing, which is, you can have soft plaque or fatty plaque, you can have fibrotic plaque, and on the right of the screen, you can have calcific plaque. Now, plain old balloon angioplasty tends to work on the left side of the screen. And then when you get to more fibrotic lesions, you need to start thinking about NC balloons, and maybe as you go further, the OPN balloons for more fibrotic and fibrocalcific lesions. Cutting balloons tend to work from fibrotic lesions onward towards calcific lesions. Scoring balloons also exist in this same spectrum as well. The chocolate balloon can be used for soft fatty balloon, fatty plaque, as well as fibrotic plaque, and the lower end of the calcific plaque. And then this is where lithotripsy starts to come in when you have severely calcified disease, and also atherectomy for severely calcified disease. And you can see that the adjunctive OCT or IVUS is flashing below, because I would like to highlight the importance of intravascular imaging in these patients. So if I want to end my talk here, I can stop. And this is actually the summary of everything. But now we will talk about some more things in detail. So, in the old days, they used to say, they used to have this TV show when I was growing up called the X-Files. And in that, they used to say the truth is out there. But in interventional cardiology, in our practice, the calcium is actually out there. This is actually relatively old data at this point, about 10 years ago, that looked at the national database in the United States, looking at lesion classification. And even in this lesion classification, you can see that probably about, the percentage of calcified lesions actually has been increasing with time. And this is a factor of the aging population in the United States and the manifestation of this disease as more older patients start coming to the cath lab. Even in acute coronary syndrome lesions, this beautiful paper by Genero, which was valid in 2014 and is still valid today, shows that about 1/3 of patients, even with ACS, have moderate to severe calcification. Now, what are the risk factors for calcification? Now we know that there is intimal calcium and we know that there is medial calcium. Now the biggest risk factor for both of these is right on the list there with the green arrow next to it, which is age. Age is an important risk factor for calcification in the coronary arteries. Unfortunately, as our patients get older, they also accumulate more mileage. They get diabetes, hypertension, hyperlipidemia. These are all unhappy diseases that tend to follow with aging. And so because of that, that tends to be associated more with intimal calcification. Diabetes can have both intimal and medial calcification. Being male itself, unfortunately, is a risk factor for calcium in the coronaries as well. Smoking is also a risk factor. Previous bypass surgery is a risk factor, and I believe my colleague, Dr. Sachdev, is going to be addressing some of the issues in dealing with patients with bypass surgery who have had graft failures. Renal etiology, some of our older patients also have issues with renal failure, and that can also result in both intimal with hypophosphatemia and medial calcification, which can also be a problem in the PCI patient. So why is this a problem? Calcification, unfortunately, is a big problem for patients with PCI and drug-eluting stent. You can see the risk of death is higher, the risk of death or MI is higher, and death, MI, and revascularization, target vessel failure is also higher. So, it is a problem all around. And this is a 3-year outcome in these patients that was studied. Now, why don't we send them all for CABG? This is a study that looked at a pooled analysis of patients. And you can see the red line is actually significantly separate, which is severe calcification. It's separate from the blue and the green lines. And the first graph here is death. This is death or MI, and this is MACE. And you can see all of these are higher in severely calcified patients post-bypass surgery. So why does calcium cause us problems during percutaneous coronary intervention? It creates problems at multiple different stages. Pre-stent, you can have dissection during angioplasty or pre-dilatation. You can have difficulty with complete dilatation. Peri-stent, you can have inadequate stent expansion. You can have prevention of stent delivery to the location. The stent may not even go there. You can have malapposition of the stent once the stent is placed. In addition to that, post-stent, you can have insufficient drug penetration or restenosis. And unfortunately for us, a lot of the patients with severe calcification have actually been excluded from major US IDE or PMA trials, with the exception of the major Eclipse trial or the Orbit 2 trials that have been done with orbital atherectomy. But when it comes to rotational atherectomy, I think the two major studies are the European studies that have been done with the Rotaxis or with the Prepare Calc trial. And now with the Disrupt CAD series of trials, especially 3 and 4, they have had significant participation in the United States. But prior to this era, patients with severe calcification in general have been excluded from most of the stent trials. And that's an important factor. Now, what is the role of plaque modification in these patients? Well, plaque modification has a significant role. It enables lesion access, number one. It minimizes vessel trauma and barotrauma due to extensive high-pressure pre-dilatation. It modifies lesion compliance and creates larger MSAs at the end. And finally, ultimately, facilitates procedural success. So these are all a summary of the different techniques that are available to us when in the contemporary cath lab that we can do. And I will go over this in detail. These are just beyond balloon dilatation. So on the first column, you have rotational atherectomy, which has been available from the 90s. And the mechanism of rotational atherectomy is basically a diamond tipped drill. And there are different sizes. There are burr sizes from 1.25. Most commonly used burr size is the 1.5 burr. 1.75, 2.0, 2.15, 2.25, 2.38, and 2.5 burrs are also available. Now, I cannot recall a time in the near past that I have used anything larger than a 2.0 burr. And I can maybe have the panel see if they can tell us whether they have used anything larger than a 2.0 burr in the last 10 years. No? So nobody from the panel is saying yes to that. So am I safe to assume that that is the case?
I only use two under 2 mmHg for the patient.
Yeah. Yeah. So in the last 10 years, I don't think I have used anything more than a 2O burr. And even the 2O burr, I think I have used maybe 3 times over the last 10 years. My most common burr is the 1.5 burr. I think there are a couple of different reasons for this. Number one, most of us have moved to a hybrid strategy when it comes to rotational atherectomy. We tend to start with a smaller burr and do balloon dilatation. Primary atheroablation strategy has fallen out of favor in the last 10 to 15 years with this technique. I think the other reason is also the radial revolution. If you are going to use 2O burr, you will probably need an 8 French guide. It is going to be a little difficult to put an 8 French guide through the radial artery in a lot of our patients. So that also tends to drive this. For rotational atherectomy, generally we use more than 6 French size guide catheters. The guide wire is 0.009. In general, the speed is 140 to 180,000 RPM. Sometimes high-speed atherectomy is needed if you need to cross the lesion. The advance is by pecking the lesion. In general, we try to make a few passes. You can have contrast in the line. You can have pictures taken during the procedure. We will move to the next technique, which is orbital atherectomy, which came about in the 2010s, probably over the last decade. The mechanism of this is orbital sanding. It involves a 1.25 millimeter crown, and the guide size is 6 French. The guide wire is actually a 0.012 wire with a 0.014 tip. There is only 2 speeds, 80,000 or 120,000 RPM. And it is generally advanced very slowly at around 1 to 5 millimeters per second. And you can actually do multiple passes, have contrast in the line, etc. Given the relative newness of this technique, osteal lesions remain a question. You cannot treat vein grafts or in-stent restenosis with this technique. CTO, long lesions, all of this are probably fair game. There have been some people who have tried to treat calcified in-stent restenosis, but then that is not recommended by the manufacturer. Shockwave came about in the late 2010s, and actually it is rising now. It works by producing a pressure wave, and basically there are 4 balloons available with IVL. In general, this again requires a 6 French guide. The nice thing about using intravascular lithoplasty or lithotripsy is you can use whatever wire you like or you're comfortable with. You're not restricted to using a Viper wire or a rota wire. You can also have a buddy wire if you need to. That is not a problem either. In general, the technique is to go to 4 ATM and have 10 pulses and then 6 ATM. A lot of us have different techniques of doing this. You can also have, you have up to 80 pulses that you can use during this case. You can have contrast in the line. You can take pictures. You can do lesion lengths that are limited by the length of the balloon, unfortunately. There is also a laser technique that is available, which has been available since the 90s. And this works by a vapor bubble. In general, most of the people who use laser tend to use laser not to actually produce the actual ablation itself, but they tend to use it more to actually produce a pilot hole so that you can then use rotational atherectomy or a different technique to then cross and achieve what you need to achieve. So let us talk a little bit about intravascular imaging. You can see on the top screen, we have both IVUS on the left and OCT on the right. And you can see mild calcification, moderate calcification, and severe calcification, which is defined as more than 270 degrees of calcification. The issue with the OCT is you're able to actually measure the thickness of the calcium, and we will see how this is important shortly. Whereas with intravascular ultrasound, you only see the leading edge of the calcium and you cannot see the thickness of the calcification. So with IVUS assessment of calcium, you can look at the arc of calcium, the length of calcification, and the distribution of the calcium, whether it is superficial versus deep, whether it is lesion associated versus located at the reference area, and whether it is concordant or discordant with the plaque thickness in that area. So these are all different parameters that you can look at with calcium. There is a nice IVUS calcium score that has been validated by the group that also did the OCT scoring. And basically, if there is calcium greater than 270 degrees and greater than or equal to 5 millimeters, that will get you 1 point. 360 degrees of calcium will get you 1 point. A calcified nodule will get you 1 point. Any vessel that is smaller than 3.5 also gets you 1 point. So in general, if you see that you score 2, 3, or 4 with the calcium score, atherectomy tends to be preferred in terms of producing better stent expansion. This is based on retrospective data. It remains to be prospectively validated. However, for OCT, there is a well-published OCT-based calcium score with a maximum calcium angle of 180 degrees that gets you 2 points. Maximum calcium thickness of 0.5 is 1 point. Calcium length greater than 5 millimeters, also 1 point. And if you meet, if the higher you score on this, the worse your stent apposition is going to be. Now, there is a study that actually compared both IVUS and OCT, and the sensitivity of both of these were much better than angiography in terms of detecting intravascular calcium. The good news is both OCT and IVUS calcium angles are very similar. You can see on this Bland-Altman plot that they are only different by about 7 degrees, which is clinically insignificant. The advantage of OCT can be clearly seen here because OCT can often be used to measure thickness, calcium thickness, but sometimes it is not possible on OCT as well. Like this is an exceptional case where you actually see that even this line, this asterisk marks actually this spot, and you actually see that you cannot measure the thickness of the calcium beyond that. So sometimes it can be a limitation even with OCT. So let's look a little bit about IVUS versus OCT for calcified lesions, because I think we need to understand intravascular imaging when we are planning complex PCI in these elderly patients. The presence of calcium can be identified by both IVUS and OCT. The arc of calcium can also be easily identified by both. Now, the type of calcification, superficial versus deep, can often be identified on both IVUS and OCT, but if both are present, it can be tricky sometimes on the intravascular ultrasound. The length of calcium can be identified on IVUS if you use an automatic pullback or a sled or co-registration with manual pullback. On OCT, you can identify the length easily. The thickness of calcium on IVUS, you cannot identify. We talked about this limitation. On OCT, you can usually identify this. However, here comes the problem. I've gone in favor of OCT for so long, but the trouble with OCT is that it involves contrast usage. And a lot of these patients who are elderly have abnormal creatinine and abnormal renal function. And you will not be able to use additional injections of contrast to get OCT images in these patients. So IVUS still remains a mainstay in a lot of these patients for this important reason. IVUS can also be used for aorto-ostial lesions. OCT has limitations in this. Sometimes it is possible with a guide extension catheter. So I want to bring up a case. This is an 80-year-old male who presented with chest pain for 1 day. Troponin I was 5. This is not the high sensitivity troponin. This is the regular troponin. And he has a past history of CABG, 4-vessel CABG, and CKD stage 3, hypertension, hyperlipidemia, and COPD. So all of these problems come with age, unfortunately. So he has had a difficult time, and his ejection fraction is 30% with moderate aortic stenosis as well, but it is not ready for TAVR just yet. We did a cath and found a freshly occluded saphenous vein graft to the second obtuse marginal. If you look at image A, you can see that this is a very heavily calcified and severely diseased circ going into the second obtuse marginal, and there is backfilling of the graft up here. In image B, we actually tried to wire this, but as you can see, the microcatheter got stuck and could not be advanced beyond this point. We were then able to advance rotowire into this obtuse marginal by direct wiring, and subsequently did atherectomy with a 1 fiber with several runs. And this is the intravascular ultrasound that is performed after that, which shows both superficial and deep calcium in this image. Given the fact that we thought that this was a large vessel based on the ultrasound, which, on the angiography, we did not have that impression, but on the IVUS that guided us that this could be a large vessel. We then decided to do IVL with a 3O IVL balloon, which unfortunately got perforated and could not hold pressure. So we had to come back and do IVL with another 3.5 balloon, which was successful. And you can see the calcium fracture marked by this yellow arrow here. Subsequently, we were able to deploy 3 stents, and you can see this beautiful result with the circumflex going into the second obtuse marginal and fully expanded stent. So finally, we talked about the classification of atherosclerotic lesions. We talked about plaque morphology and therapeutic strategy and how these are related. We talked about coronary calcification. We talked about different techniques beyond balloon dilatation that can be used. We talked about intravascular imaging, which I believe is important. We also talked about how this all comes together in a geriatric case. So finally, calcified coronary artery disease is common in our elderly populations. And comorbidities are unfortunately common in these elderly patients. We need to be familiar with these complex PCI techniques and intravascular imaging in order to optimize results in this challenging subset. Thank you very much.
Thank you very much for the great talk from Dr. Kumar. You have us an overview and also a lot of comparison between the methods to optimize the result for the calcification. I think that through your presentation, there are 2 points is really important. Is first of all is to evaluate the calcification, and the second thing is how to combine the method to deal with the calcification. So back to the first part, which method you think is most suitable and cost effectively to evaluate the calcification when we do the PCI? Dr. Kumar?
I think everything starts with good basic angiography technique. And I think it all starts with good visualization of the calcification by angiography first. I find it necessary to make sure that sometimes we take good angiographic pictures, maybe with 15 frames, and a good setting on the machine. Sometimes maybe a little bit higher radiation initially, but that gives us a good picture, good visualization of the calcium. And if you really notice severe calcification there, we may be able to not do further intravascular imaging and identify the severe calcium from angiography itself. Then the next step is intravascular imaging, which is very important in these patients. We talked about IVUS and OCT. There is also different options. If you have cardiac CT available, sometimes you can identify lesion-associated calcium on cardiac CT even before these patients come to the cath lab. But getting a CT in every patient may not necessarily be cost-effective either, and I would not recommend that as a strategy. To say, okay, we are going to take the patient off the table and go get a CT. No, I don't think that is the correct strategy.
Yeah, thank you very much for the clarification for that. So the second thing is how we consider the calcification, because somehow, like when we do the preventive for the patient, the calcification of the plaque is a sign for the effectiveness of the prevention. But when we do the PCI, the calcification usually is considered like an obstruction for our PCI. So, for example, like in the acute setting, when you see the very calcified lesion, what should we do? Should we go ahead and do a lot of plaque modification, or we just leave it there? Because the chance of the future event is low. I would like to listen to your opinion first from Dr. Kumar and then from Dr. Rajesh.
So the problem with the acute setting is that it's not necessarily true that the risk of the event is low or the risk of the future event is low. I can show you several cases that we have done over the years where, the risk of subsequent ACS in these patients can actually be pretty significant. In fact, I remember one patient with a circumflex that looked very similar to the one that you saw, where it was left alone. They said, okay, this is 60%, is stable calcium, left alone. 1 month later, the patient is back again in the hospital with a heart attack, and then they left it alone again. And so then, this has now been 4 months. He has had 3 admissions in 4 months with non-STEMI, and this is the culprit. Everything else is open. And so I think it is a little difficult to say that just because it is severely calcified, all severely calcified lesions are benign. I think we need to look at the physiology, which is a very important part. If you do a FFR and the FFR is highly significant, by the way, that patient I'm referring to had a IFR of 0.31 across the lesion. So, if I think it is important to understand the physiology and do the FFR in some of these controversial cases. And then that can also be used to justify if you need to do a complex PCI. If you do the IFR and maybe it is 0.88, then maybe most of the calcium is medial calcium. It does not encroach much on the lumen. Maybe there is some borderline issues. You might be able to leave it alone or manage it medically if the patient is complicated. But if you get an IFR that is 0.31 or 0.41, it is difficult to say that you are going to ignore that and leave that alone. So I think physiology guidance can also be very helpful in these kinds of scenarios. Dr. Sachdev, what do you think?
No, I totally agree with you, Dr. Kumar. I think starting out a good angiography will help you identify that there is a calcium. And if there is a lesion that you think could be a lesion which could be a culprit, you can assess that and know the physiology of that lesion. So you can do a FFR, RFR, IFR, and then you know that this patient is ischemic or not. Following that, you can use a IVUS catheter. And if your IVUS catheter crosses through there, you will be able to assess that lesion. And you will be able to know the amount of calcium which is there. Now, if your IVUS catheter does not cross the lesion, you know that you're dealing with a very heavily calcified artery. So you probably want to then go to your atherectomy directly. Now, if you are able to cross the lesion with IVUS catheter and you know that there is heavy calcification, you can then sort of think about, well, will one strategy of just atherectomy alone is going to be just sufficient for this particular patient? Or am I able to sort of assess there is more deep calcium? So you can sort of further risk stratify that guy with a OCT, depending upon the creatinine. Now, if you do, somebody with a renal failure, you don't want to use more contrast, but then you can actually apply OCT and understand more the depth of the calcium, whether this is superficial calcium or you're dealing with both superficial as well as medial calcification, and how much of that is there. And then you can sort of strategize that I am going to do atherectomy followed by a intravascular lithotripsy, because all these atherectomies, besides orbital atherectomy, rotational atherectomy is just going to be effective on the superficial calcium. It may not have an impact on your deep calcium. So you probably want to apply orbital atherectomy, or you want to do a rotational atherectomy to create a little hole so you can deliver the intravascular lithotripsy balloon, and then actually really try to break or fracture the deep calcium which is there. So you can actually achieve a good stent implantation as well as stent apposition and expansion.
Yeah, thank you very much. And actually, both your faculty already explained the way we were dealing with the calcification when we do the PCI. But back into the reality, because in the low setting like in Vietnam, somehow we have not many tools in the CAT lab. And for calcification management, usually you need a lot of tools to overcome this situation. So the question here is, which device we use first to reduce the cost and also to improve the effectiveness? Should rotablator be the first choice for the calcification reason? I would like to listen to the option, the comment from Dr. Kumar first, and then Professor Ho Thung Dung, and then Professor Pham Anh Hùng.
Thank you. I think now I'm going to just ask a quick question. So in Vietnam, you have rotational atherectomy available?
Yes, almost
and
in
you have
many centers.
IVL available?
Not yet so far.
Okay. Orbital atherectomy not available?
In some center, but not
Some
very
centers
common.
it's available. Okay. And laser, I think, is a less limited modality. So I think rotational atherectomy is very reasonable as the first choice in most patients. Okay. Given the situation in Vietnam at present, I think this is a very reasonable first choice in most patients. If it is a large vessel, or if there is significant superficial and deep calcium, it is reasonable to say you want to have orbital atherectomy as a choice, because for a large vessel with orbital atherectomy, you can get good results. When I say large vessel, I mean 3.5 and above. With the rotational atherectomy, you may need to use a larger burr sometimes if you want to get to that, and sometimes you may have to use 2 burrs to get to that. So sometimes you may need to think about that option as well. But yes, I believe that rotational atherectomy is a very reasonable first option in a lot of these patients. Now, as progressively more techniques become available, you will find that intravascular lithotripsy or IVL will eventually be a very good technique for a lot of these patients, just because of its simplicity and ease of use. But the price will be a major concern.
Yeah, thank you, Dr. Kumar. So I'd like to listen to the comment from Professor Ho Thung Dung.
Okay, thank you so much for your question, Professor Nguyễn Ngọc Quang. And I like to come back the last question. Very interested the situation when we have one acute coronary syndrome, QMI, in combination with calcification lesion. I think by now, according to intravascular imaging classification, we have three types of the lesion. The first, the plaque rupture, the second, plaque erosion, and the third, calcium nodule fracture. So if we meet one case, look like Professor Nguyễn Ngọc Quang give acute coronary syndrome with thrombus, and we have calcification, what we can do. I think we need to determine exactly with the mechanism, with the IVI, and maybe IVERT or maybe OCT, because we should remember not all the case with a QMI or STEMI such as we can complete our perform, because sometimes less burden of thrombus, we can improve the blood flow and relieve for the patient improve, and then we come back to do 1 week later. So if we use IVI to assess if the patient large thrombus and in combination with the calcification, I think we must do improve the patency, improve the TIMI flow for TIMI 0 become TIMI 1 and TIMI 2 and TIMI 3, and we stop, and we increase the potential of the anti-thrombotic therapy, and maybe 1 week later or 2 weeks later we come back to do. If we determine it's the calcium nodule rupture, we must do. Or calcium plaque rupture dissection we must do, because if we don't manage the dissection of plaque rupture or nodule dissection, the patient is terrible. I think so, but I think not all the case we can manage successfully. About throat bladder in Vietnam, I think by now we have the commonly 1.25, 1.5, 1.75, and 2.0. And until now, I just do to 1.75. But in some case, when I have the lesion, very calcified lesion and large burden calcified lesion in the left man, particularly in the left man, the large burden of calcified very large. So when we use the pearl not large enough, it's very difficult. We can do the patency for the blood flow. We can in combination with cutting balloon or scoring balloon, but we cannot deploy the stent in the left man with very large burden of calcification, because we don't affect to rupture or to hysterectomy. So I think by now we need some more potent weapon, potent armament, look like lithotripsy or laser. I don't know. So it's my opinion.
Yeah, thank you, Professor Ho Tung Dung. Due to the time, I would like to listen to the last comment from Professor Phạm Mạnh Hùng. What do you think? Which device and which strategy should be the first priority for calcification management in when we do PCI for the elderly patient?
Okay, so far we only have rotablation. So in our practice, I think that if first we can cross the lesion, we just only using the balloon first, and then doing the balloon with the high pressure balloon and doing the stenting. But if not, and also have heavy calcification, I attempt to using the rotablation with the not too big burr, just only to make a facility for PCI, just in our real day practice in Vietnam. Yeah. So I just said just only some experience like that.
Yeah, thank you, Professor Phạm Mạnh Hùng. For the interest of times, and we need to move to the next talks. And I would like to introduce Professor Ho Tung Dung to present the topics optimal PCI in the elderly, kids or cheap. Yeah, Professor Ho Tung Dung, please.
Thank you so much for your introduction. Can you see my presentation?
Yeah, we can see now.
Okay. The first, I'd like to talk about the elderly patient in the PCI. But you know, by now, the elderly patient account for majority of case come into the cath lab. According to the definition of the elderly, look like in the Vietnam, greater than 60 years old is the elderly. In our patient, but in the cath lab, 60 years old, I think account for greater half of the patient, 70 years old, 20%, 80 years old, 12%. So, and by now, we have many PCI involved trial and registry include the elderly, greater 75 years old. So I think from the viewpoint of interventional cardiologists, the elderly patient often should greater 75 years old. And by now, according to the data, this is the data from America in the cath lab in the time 2008, 2014, it means the 6 years. After the 6 years, the octogenarian doubling, as you see. And this is in the data, the nonagenarian in the data of the Dr. Go and Dr. Gupta, and in the 10 year from 2004 to 2014, the percentage of the nonagenarian increased 50%. So it's a proof for population patient, elderly population account for majority of the patient go to the cath lab. And I like to say something about, because today our program broadcast live to the meeting of geriatrics meeting in Hanoi, and there are many young doctors, many young geriatricians. So I say a little bit detail about here. As you see in the right, the picture in the right, the old man with the 100-year-old, and he set the record marathon in 2011. And you can compare to the right, the young guy with the 50-year-old, but he suffered from Alzheimer's disease, and all the day, all the time, he on the bedridden, no do anything, no think anything, no enjoy anything. So who is older? Who is appropriate for PCI? So we have the concept. Oh, look like it. Biological age, and 152 is the chronological age, but we must set the biological age. Why are elderly different, or what makes elderly different? Aging process have effect on the cardiovascular system, impair endothelium function, so more prevalent for risk factor, impair function of the sinus node, so very easy to arrhythmia, bradycardia, increase stiffness of myocardium on vessel wall, reduce response to the baroreceptor, beta adrenergic receptor. So maybe they, when the elderly fall into the cardiogenic shock, maybe vasoactive drug work not effectively, every function decrease. And the net effect, large reduction of cardiovascular reserve reduce. And if it reduce when the patient fall into the compromised hemodynamics, it's very easy to fall into the cardiogenic shock. And what are the elderly different? This is the age-associated condition. It do explanation for the biological age. The first, the elderly have the chronic kidney comorbidity, multi-comorbidity, chronic kidney disease. It's very vulnerable to the contrast agent. Chronic anemia, very vulnerable to bleeding. Chronic lung disease, very acute respiratory failure. Altered drug metabolism and distribution of drugs, hormonal regulation change, and the last look like in the presentation of Dr. Nguyễn Huân, frailty, disability, cognitive dysfunction, and aging process have effect on cardiovascular system, particularly for PCI. As you know, atherosclerosis disease affect not only in the coronary artery disease, affect all the artery, look like peripheral artery disease. So we have a poor vascular asset. And in the coronary artery, they often have the dilatation, tortuosity, medical calcification, or diffuse multi-atherosclerosis, multivessel. It makes the interventional cardiologist sometimes get reluctant or not determine which lesion is the culprit lesion and which lesion is appropriate to fix. So it made the PCI in elderly require advanced technique and more as the instrument. And we turn to the picture again. We have the picture one woman 78 years old in the left, and one woman 85 years old in the right. In the left, the woman is bedridden. They must intravenous nutrition or someone. And in the right, in spite of her have older, but her can take the participation in the race for the elderly. So who is appropriate for PCI? I think certainly all the interventional characteristics to the right woman. So in the my topic is optimal PCI in the elderly, kit or chip. So what is KISS? KISS is the chip. KISS is simple and stupid or safe. It means when we do PCI in the elderly or previous strategy, KISS keep it simple and safer. How we can do? The primary goal to improve the quality of life, no lengthen the life. So we treat only refractory symptoms, we treat culprit lesion only or culprit artery only. We treat the main vessel, we treat the large branch only. And we consider biological age, comorbidity, and risk of complication. It means we keep the procedure simple, safe, always pre-dilatation with balloon before we do stenting. Consider radiant approach for reduce the bleeding risk. And what is the chip? The chip, complex high-risk interventional procedure, complex high-risk indicating procedure, complex higher risk interventional patient. And nowadays, sometimes we call shorter complex PCI or high-risk PCI. It means we do the intervention for very complex anatomy lesions, such as the CTO, such as the left main, the triple vessel disease, in the patient very high risk for complication. It means comorbidity, kidney, chronic kidney disease, or heart failure. So the patient very easy to fall into the compromised hemodynamics, acute heart failure, or cardiogenic shock. So according to the definition of SKY 2020, a complex PCI, it means the first anatomy, multivessel calcification. We have just listened to the presentation of Dr. Kumar. And comorbidity, diabetes, cardiogenic shock, valvular heart disease, acute coronary syndrome, heart failure, so on. And the last, the consensus of the SKY 2020 give more. To do the PCI in this complex PCI, we must need to more equipment to such as we need intravascular imaging, IVR, OCT, intercoronary physiology, FFR, IFR, guide, catheter extension, urethral, special coronary wire, special balloon, cover stand, atherectomy, rotablator, orbital atherectomy system, intravascular retractable gypsy laser, and polyprotection filter wire, mechanical circulatory support, balloon pump, impeller, ECMO. And by now in Vietnam, we have IVRS, OCT, FFR, IFR, microcat, Gidezella, a special wire, special balloon, cover stand, rotablator, just only rotablator, filter wire, balloon pump, and ECMO. And so by now, many authors say, by now, PCI in the elderly in modern area is the constant tension between kit and chip. Because in the patient, elderly patient, the lesion often very complicated, very diffuse, very calcification. We cannot do with the simple methods. And we must consider between PCI and CABG bypass surgery. This is the role of the heart team. To the right side, if prefer bypass surgery, to the left side, to the right side, prefer for intervention, we must consider guideline based on preference, resources, operator skill, complex of the lesion, the breadth of ejection fraction, diabetes, high frailty, comorbidity condition, EGFR score, STS risk, no emergent clinical intervention. So the interventional cardiologist, when we have the plan to revascularization for the elderly patient with the coronary artery disease, we must consider two revascularization strategy, bypass surgery and PCI. But we have the very important role of the heart team. So, in my opinion, in my experience, how to solve a complicated problem, it means how to do the PCI in the elderly. The simple case we can solve with the simple way. The difficult case should be tried in the simple way if possible. But however, the complicated could just be many successful with chip only. And so it is some summarization, some theory for the PCI in elderly patient. And by now I like to have the three case for the demonstration. The first case, left band PCI and CTO in the right coronary artery. So it means the left is last remaining vessel. It's very important. When we do the last remaining vessel, if something happens, the patient lost or hold the blood flow for the heart and the patient fall into the cardiogenic shock. Terrible. In the right, CTO and calcify. In the left, you can see the few lesion from the left man, but the mind, and particularly in the proximal and mid segment, and you can see the left give the collateral to the right. By now, the patient have a chest band and non-STEMI. If we do to the left coronary artery, you can get obstruction, total obstruction of blood flow, and very easy to deal to give to lead to the complication. And in the left coronary artery, it have a small aneurysm. You can see small aneurysm. And our strategy, if we can open the CTO in the right coronary artery, it means we can get the native circulatory support, not mechanical circulatory support. We can break down last remaining vessel. So we try to do CTO PCI. I know in here we have some expert of the CTO PCI, look like Dr. Nguyễn Ngọc Quang, Dr. Ngô Minh Hùng. I try to do, and very lucky. Lastly, we can get successfully. After we get successfully and standing for the right, the problem become simple. Because as you see this picture, the right give back collateral to the left very abundantly, so we can do the PCI to the left. No worry about the compromised hemodynamics. So we do, and by now we in my cath lab we have the neurological intervention equipped. They can cause coiling the aneurysm very quickly. So I like to call him before I do post dilatation, very high pressure in this area because it's very calcified. And the last result, the right. You can see the right after we open the CTO, it can give backward the very abundant collateral to the lab. And we can do safety the lab coronary artery last remaining vessel. Okay, this is the first case. And the second case, I think that the second case it cannot solve the simple way because left main PCI with the calcified tortuous small diffuse disease. What you see in the right is the tortuous a small diffuse and calcified lesion in the right. And the left we can see very calcified and tortuous. In the ordinary practice, in the daily practice, if the patient have the not severe, look like this guy, I don't touch to the coronary artery disease because coronary artery because it's very easy to make some dissection something, but because I like to do the PCI to the left, we try to open some parts in the right and upscore all the case the patient refuse or deny bypass surgery or sometimes cardiac surgeon deny because in this look like this guy they say a very calcification and very difficult to insert the graft to coronary artery. And we try to open from the ostium to the segment to the midst of the RCI. It look like better, I don't know. Better or not better, I don't know. But I feel more confident to go to the lab. We go to the lab. Upscore in this case, we must do rotor-ablator. Because if we use only the cutting balloon or scoring balloon, it makes many dissection and overlap, very easy to get stuck to fail. We try to a rotor-ablator. After we do a rotor-ablator atherectomy with the support of the guided Zilla, we bring the digital stand to the mid of LAD first, and then the proximal segment with the second stand, and this is the last result. So until this case, we cannot solve the coronary artery disease in this patient with a simple methods. And one more case, you see very severe calcification of the distal left main involved to the ostium of the LD and circumflex. How we can solve with the simple method? I think no, we cannot. How we can solve with the cutting balloon? I think no. So we made decision to solve the problem with the rotor-ablator. First, we try to pre-dilatation with the small balloon, and we use the per 1.5 for the LD first. After we do the atherectomy in the LD, we deploy the distal stand first, and we go to the circumflex and we burr again. Atherectomy to the ostium of the circumflex. And by now we do the two-stand technique. Okay, cross. And this is rat result. And the last case for demonstration. Left distal disease with qualification. It means bifurcation, trifurcation, and qualification. This patient were done the coronary angiogram for a long time, and she denied to circle bypass surgery. And so she suffered a check band for the long time. As you see, in the distal left man, we have a trifurcation, a qualification with the LAD circumflex and diagonal intermediate radii. And this is the large result. Up score, we should do triple kissing balloon. Large result. And the patient will follow up until now, 2022. This year, the patient will get coronary angiogram. It's okay. We use inverse it a little bit, the restenosis. So in my opinion, in my experience, how to solve the complicated problem, how to do this in the elderly, the simple case can be solved in a simple way. The difficult case should be tried in a simplest way if possible. And the complex or complicated, it could be managed successfully with chip only. I think so. And the take-home message, coronary artery disease in the elderly are often very severe, diffuse, tortuous, heavy calcified, particularly type C, bifurcation, left main, triple vessel disease, CTO. PCI in the elderly require advanced technique and assistance instrument. We should have a good, appropriate plan or strategy before to do PCI in the elderly. We should do assessment of frailty, look like the presentation of Dr. Huang, and predict some difficulty, obstacle to overcome. In the case of very challenging left main disease, many stage PCI may be reasonable, acceptable choice in older patients, particularly very high procedure risk. And we should have some requisite ability, IVI, plug modification, plug defogging, cutting balloon, protoblator, and we should have a mechanical circulatory support nearby. And we must do with a good team or teamwork. Thank you so much.
Yeah, thank you very much for the excellent presentation, actually. And the time is a little bit beyond the schedule, but I think we have to open for the discussion because it's very interesting presentation. So first of all, I would like to ask Dr. Rajesh about how to approach the patient like this, because Professor Ho Tung Yong gave us a lot of very real complex lesion. So how do you deal with the kind of lesion, for example, the CDO on the right side and the very significant lesion on the left side? So according to your opinion, what is your approach in your center? Dr. Kumar, Dr. Rajesh, yeah. Yeah, Dr. Rajesh, yeah.
That was an excellent presentation, and you showed some of the most difficult cases and how you tackle those cases. Now, as far as the first case was concerned, where there was LAD disease with robust collaterals going to the right coronary artery, and the right coronary artery was a CTO, as well as the circumflex coronary artery was also a CTO. In US, probably we will do actually a hemodynamic support and address the left anterior descending artery, and simple reason being that is the artery supplies the majority of the myocardium. Because the lesion is quite tight, is calcified, and then after the LAD has been revascularized, and the CT of the right coronary artery and CT of the circumflex artery can be addressed at a later date. So that's how we will probably address that particular patient in our lab. However, what you described is also very acceptable, that CT of the right coronary artery can be addressed first. However, there could be some challenges at times opening the CT of the right coronary artery. And if those challenges are there, then you have to resort to coming on a retrograde, because there are robust collaterals from the left anterior descending artery that you can utilize to come retrogradely and revascularize the right coronary artery. So those will be my sort of way to address the coronary artery disease in this particular patient.
Yeah, thank you very much. And according to the previous presentation from Dr. Kumar, I think, so with the calcified lesion, I would like to ask Dr. Kumar that we talk a lot about the device, single device only, or we have to combine devices together in order to dealing with the calcified lesion, because nowadays we have to rotablate our orbital before we put the IVL inside. So we have a lot of study coming in, like IVL with the orbital, IVL with the rota. So even the rota in Vietnam, we use the rota and the high pressure balloon. So according to your experience, so should we use the combined therapy in order to dealing with the severe calcified lesion? Thank you.
So that's a great question. I think that has a lot of bearing on a lot of things. So I think the first and most important point is that, we should not be doing combined modalities just because we can do combined modalities. Okay. It is not a matter of pride or glory or anything of that sort. It is a matter of what we can achieve and get an optimal result for the patient. I think that is the first and most overriding concept. Now, I recognize the fact that, especially in elderly patients, sometimes we would like to maybe avoid femoral access. And, if, you cannot get a big enough burr and it's a large vessel, you may have to use two modalities,
Yeah.
Typically, you may have to use rotational atherectomy followed by shockwave, or you may have to do orbital atherectomy. Orbital atherectomy combined with shockwave, it is possible, it has been reported, but I do not see any specific reason for that, because they both ablate both intimal and medial calcium. So I don't see the need for duplicating that. Whereas with rotational atherectomy and IVL, I see some potential synergy between the two, where one takes care of the superficial calcium, creates a pilot hole, and the shockwave then takes care of the deeper calcium. So I can see that, but I don't see a reason for some of the other combinations as to why they come about. However, different techniques may be necessary in different areas. Second important point is resource limitation. So, if you're functioning in a scenario where resources are limited, or certain technologies may not be available, like, for example, IVL, you were telling me earlier that IVL itself was not available.
Yeah.
Then you have to work with whatever techniques that you have. And typically that would mean that if you have rotational atherectomy, you may subsequently need to do, you may subsequently have to use a cutting balloon if IVL is not available. And rotacut is actually a very good strategy for complex PCI for severely calcified lesions. And so that may be a very cost-effective strategy with the cutting balloon following rotational atherectomy as well, that can solve some of these issues. So I think you have the combination strategies. You can combine them in a suitable manner to get what you need. Now, if you have invested and purchased the intravascular ultrasound catheter, there is nothing to stop you from, after you do the rotational atherectomy and a balloon inflation, to quickly put the IVUS there and see what has happened. If you have achieved the calcium fracture, then you can expand it and deploy the stent successfully. But if you have not achieved calcium fracture, then you have to go further, and whether it's a cutting balloon at that point or whether it's going to be IVL at that point, that depends on what is available and what the resources are. Thank you.
Yes, thank you very much for the excellent answer for Vietnamese doctor. And I think that we have limited of time, so I just have the last question for Professor Phạm Minh Hùng, that in PCT this year they talk a lot about the more is more and the less is more. More is more, that we use a lot of device in order to get a good outcome for the patient. So for this the elderly, and with the presentation of the Professor Hồ Thiên Dũng, so Professor Phạm Minh Hùng, what do you think about that? We have to use the imaging device or even the physiology in order to evaluation the lesion, and a lot of device in order to get a better outcome for the octogenarian patient when we do the PCI for them. Thank you.
Thank you so much, Dr. Hồ Minh Hùng. I prefer the less is more. It's my also philosophy of the practice. When I was young, I want to use a lot of the modality for intervention and want to do a lot of complex case. But nowadays I get more and more older, so I just thinking that less is more. But in my opinion, it's quite depend on the lesion. When we use coronary angiography first, we saw the patient and we can evaluate, and also based on the patient situation when we decide. So I think it's most of cases we just only using the choangiography to decide for intervention, but it's some very complex case when we need to use some further modality like FFR or the IVUS, we may use, but I think I prefer the less is more. Thank you.
Yes, thank you very much, Professor Phạm Minh Hùng, that we have to escalate with the situation required to have to escalate in order to get a better and good outcome for the patient. And I would like to thank you, Professor Hồ Thiên Dũng, for the excellent presentation and the discussion from the panelists. Because the shocks of the time, and I think that I would like to invite Dr. Rajat with the presentation about the percutaneous coronary intervention in patients with graft failure in the elderly patients. Dr. Rajat, please.
Thank you so much. I want to thank the organizing committee for Vietnamese Society of Interventional Cardiology, and the Association for Gerontology and Geriatrics to give me this opportunity, and Dr. Talk Nguyen, thank you for inviting me to actually share my thoughts with such an elite group of people in Vietnam. So the topic which was given to me is the percutaneous interventions in patients with graft failure in the elderly patients. I have no disclosures for this particular talk. So CABG remains one of the best therapies for advanced coronary artery disease in elderly. And the most common conduit which remains is the great saphenous vein. However, there is a higher failure rate when it is compared to the arterial grafts. Now, the pathophysiology of saphenous vein graft failure is divided into three processes.
Excuse me, Dr. Rajat, please share full screen, please.
Full screen.
Yeah.
Okay. And can you see that?
Not full screen.
You You go in the slideshow in upper slideshow.
Okay, I'm gonna
Yeah.
skip.
No.
I'm gonna go into slideshow.
Yes, slideshow, and go to the left.
Play
Yeah.
from the start.
Yeah.
That.
Click.
Okay, can you see that?
No.
Okay.
So when you're sharing the screen, you may have shared the wrong screen. That may be the problem.
Okay.
Okay.
Oh, good. Oh, we saw it for a second.
Okay. So
I think we can see clearly.
I think that was also the issue last time also. And there is some sort of a second issue. So let me give me 1 second if I can try to figure this out. And
I think you can continue to.
okay. All right. So you're seeing this other screen, the smaller screen with the pictures there.
Yes, we are seeing the small screen.
Okay. How about now?
Yeah.
Yes,
Okay, now.
big screen.
Okay. All right. Okay. So, okay. Sorry about that. So, so pathophysiology of saphenous vein graft is divided into about 3 modalities. One is the acute thrombosis, which usually happens early on after the bypass graft, results as a result of either poor technique or a lot of inflammation leading to acute thrombosis. Now, if a graft survives that acute phase, the graft can respond in terms of aggressive inflammation with intimal hyperplasia, which can also lead to graft failure. This usually will happen within the first year of a graft implantation. And after a year or so, there will be atherosclerosis, which will set in that particular vein graft. And this atherosclerosis is a bit different compared to atherosclerosis of the coronary arteries, because the atheroma, which is there, it is soft and more friable and has a lot of foam cells. Now, how do you prevent the vein graft failure? There are things which can be proposed that pre-surgery you can actually screen, do vein mapping, and to look at the best veins which are there before you harvest them. During surgery, you can be meticulous. However, the things which have been proposed, which includes endovascular, non-touch or touch techniques, haven't really not teased out one is superior to the other. And then post-surgery is your risk modification and adding a aspirin along with clopidogrel for a period of 3 months to 6 months, which may improve your graft patency. The other options which are amenable are most likely percutaneous options when there is a graft failure. So if there is graft failure, which is more focal and is amenable, then you can utilize a stent in that particular vein graft. And if the disease is more extensive, then one may resort to revascularizing the native vessel, revascularization. So I'm going to go over two particular cases of graft failure where I would highlight how you can actually tackle a situation of a graft failure in these particular patients. So case one is a 76-year-old man with past medical history of coronary artery disease, hypertension, atrial flutter. He had ablation for atrial flutter. He also has hyperlipidemia. He presented with fatigue and shortness of breath. And he had bypass surgery in 1998, and this patient presented in 2022. He had several interventions which have been done between these years. So his coronary angiography, as you can see, showed a chronic total occlusion of the right coronary artery. You can see there has been a stent in the right coronary artery, especially the mid segment, as well as you can see the stent in the distal segment. The left coronary angiography shows that the left main artery is heavily calcified as well as stenotic. It actually just gives up a small caliber circumflex artery, which sort of further gives out one obtuse marginal, and that doesn't supply much of an area. However, there are two stents which are visible there. One sort of fills partly, the other one is totally occluded. And one is in the LAD, the other one goes to the ramus intermedius artery. Also seen in this particular image is that there has been probably two stents which have been placed in a saphenous vein graft. Picture number 3 shows that there are some collaterals which are epicardial collaterals which fill up some portion of the distal right coronary artery. Now, in this cranial view, you can see that the distal right coronary artery is being filled. There seems to be some stents in there. Seems to be a smaller caliber vessel, maybe underfilled. And Lima to LAD graft is well patent, which provides collaterals to the right coronary artery also. So the graft angiography showed that there is a vein graft which has been stented in the past. This is the vein graft of the right coronary artery. You can see that there are at least 2 stents in the proximal segment, and there is another stent in the mid segment of the vein graft, and it is 100% occluded. Now, the vein graft to the obtuse marginal, you can see that there are stents where it is actually anastomosed to the ramus artery, or rather ramus artery, and there is an osteostenosis of the vein graft. So at this time, because there has been osteal disease of the vein graft, we thought maybe revascularizing the native ramus artery will be much more optimal and durable technique. So we opted to go for the CT of the ramus artery, since there was already a stent there. So there is a, you can see a roadmap already there. All you have to do is just follow the roadmap and get to the other side of the ramus artery. So we can see that a wire, which is I think a Gaia second wire, which was tried, and you can see the Gaia second has gone in a different place rather than just tracking into that stented area of the ramus artery where it is occluded. Further attempt going upward, trying to steer the wire in a different direction. It goes upward for a shorter segment, but then exits out again. So after several attempts with several wires, this was strategy was given away, and then we resorted to actually going for the intervention of the saphenous vein graft to the ramus artery. This is the intravascular ultrasound, which shows that majority of the plaque, which is at the ostium, is fibrotic. There is very little, if there is any calcium there, and a stent was placed. You can see there is a waste in the stent, and this was dealt by a bigger balloon with a higher pressure inflation. And following that, you can see the IVUS was repeated. The stent is well opposed, and the flow in the vein graft to the ramus is restored. However, the graft was anastomosed to the ramus one limb. There is a second limb of this ramus artery, which is connected with a sort of rather very diseased portion of that branch, which has been sort of grafted. Hence, this could be ischemic, and it will remain ischemic. And there is no good option to actually really go back and try to open it from the vein graft side. But however, we have revascularized the vein graft and hope that this vein graft remains open and continues to supply at least one branch of that ramus artery. However, the patient came back with an instant restenosis in spite of a good result. As you can see, once the graft starts failing, it is bound to fail again. And now this patient has instant restenosis to the point it is difficult to engage the graft, and it is difficult to even sort of visualize it. So at this point, we decided that we're going to now utilize probably both antegrade and retrograde injection to see how we can best sort of best address this, okay? So initially, after some discussions, we decided that we're going to actually try to approach this vein graft via retrograde approach. And there was, the reason we did that was because we were able to get into the vein graft and actually were able to succeed in getting a guideliner to go in there and take a picture. As you can see, the stenotic segment is up here. The guideliner is sitting very well, so it gives us a support. So that gave us an option that we can use this and try to get back from this particular side and come retrogradely and see if we make some purchase retrogradely, then we can probably see how this antegrade will work. Maybe we can do the antegrade dissection and push the wire come further. However, as we started the intervention on the vein graft to come in a retrograde fashion, we used a Suzuki, which is a double lumen catheter. So we were able to bring in Suzuki down here and get the wire out of the second hole, which is there, to turn this way. So we thought this will give us a little support while we are trying to push the wire. We initially tried a Fielder XTA. This was followed by a Pilot 200. This was even followed by even a Confianza Pro 12. But none of this actually worked. Every wire which we tried, actually, the minute we actually pushed it further, it would collapse into the vein graft. So then we came up with a Supercross, which is a catheter which has an angle. So we said, okay, we're going to put a Supercross there. And maybe if we can hold that angle towards that and push the wire upwards. And that didn't even work because in spite of that angle, the wire kept on collapsing back into the ramus artery. So then we decided that we're going to actually inflate the balloon in the stented portion of that artery, and then push the wire retrogradely, and maybe that will sort of work. And we were not able to actually get the wire up retrogradely. So we left this wire as a marker that this is the place we have to come from the antegrade end. So then, even though the first antegrade attempt was unsuccessful, this was a two-operator technique that both operators actually, this is me and Dr. Kumar working together, and we tried to come in a antegrade fashion, just leaving the retrograde wire up here. In this particular picture, you can just see that we have one wire which is in the retrograde limb there, as well as the second is a supercross. We're trying to rotate and trying to push this wire, which did not work. So initially, we tried to come with the Gaia second, and we made some advances to the stent. We thought we are inside the stent. We tried to push it further, and then everything collapsed. So once everything collapsed out, then we actually used a Suzuki catheter and a parallel wire technique, and try to see whether both operators can try to actually do come in this particular portion and see if one can get in there, maybe second can follow also, and see whether we can actually make some purchase there. So as you can see, the wires actually exiting. One is going upwards, the other one is going down. After several attempts, we were able to actually get one wire in that particular stent. We're able to sort of push it through, follow with the second, kept the support on. And as you can see, we made some advances further. This is the Gaia second wire. As the Gaia second wire further went into the stent, we were able to see from the injection from the vein graft that we have come to the distal end of that CTO cap, and we were then able to puncture through there, redirect. It was pointing up, and after we injected, we thought that this was pointing up. We could point it down, and we were able to push through. And once we were able to push through, we went through into the ramus. Then this was followed by a rotablation at 200 RPMs to cut through the whole thing, and even cut through the stented portion of the stent, which was across from the vein graft to the ramus. And this was followed by multiple balloon angioplasties and 2 stent placements. And this was the end result, resulting in a good flow in both limbs of the ramus artery. So my second case is a 72-year-old with coronary artery disease, hypertension, diabetes mellitus, hyperlipidemia, atrial fibrillation, provoked PE, was treated with the Aliquis, PTSD, peripheral arterial disease, who presented with angina. He had a bypass surgery done in 2004. These are the angiogram pictures, which shows that he already has multiple stents, and there has been several graft failures. You can see from 2018, the stents which are in the circumflex artery and the obtuse marginal 2 are rather patent. The first obtuse marginal is occluded, and it's sort of a flush occluded. You don't really know exactly where it is occluded. It also gives some epicardial plateaus to the right coronary artery. The right coronary artery, you can see, has a stented segment in the mid portion. Then in the distal segment is diffusely diseased, and it sort of gives off 2 very small branches. Okay, one cannot make a determination that these are either the PDA or PL branch, or this is some other insignificant branches. Lima to LAD is patent. There is a disease after the anastomosis of the Lima. So this patient came back with angina in 2022. And at that point, the FFR there was a lot of progression of disease in the anastomotic or post-anastomotic lesion in the Lima to LAD. This was FFR. The FFR was significant. So he underwent a stent to that with improvement in symptoms, but then had more symptoms. In this particular angiogram, you see the only remaining two areas which are not revascularized. One is the right coronary artery, and the second is the obtuse marginal, which is sort of flush occluded. So since the right coronary artery is the one which is the relatively bigger area out of the two remaining areas, so we thought that may be probably the lesion we can actually address. We also did a cardiac MRI for viability, and the inferior wall was viable. And you can see in this particular angiogram that there is a stent, and this stent is most likely in the vein graft, and it is placed just before the anastomotic site to the RPDA. And you can also sort of see in this particular video that there is a continuation of this to the posterolateral branch. This was not initially recognized, but later on it was sort of recognized that this is the jump portion of the vein graft and not just the posterolateral branch going this way, because it will be very odd for a posterolateral branch to just go this way and then also go backwards. So it was realized that this portion of the is a vein graft, and it's a jump graft to the posterolateral branch. And you can see that there has been a progression of disease even in the stented segment and the distal segment of the right coronary artery. So initial attempt to open the CTO was made. We were able to sort of come parallel to where the stent was, and we ballooned that area. And we thought that we are in the posterior, in the RPDA at this point. However, after the ballooning, you can see that there has been a staining, and that stain just stays there. Okay, so at this point, we sort of changed strategy. We said maybe we need to try to go to the posterolateral branch, and an attempt to go to the posterolateral branch was made. And you can see that the stain keeps on getting worse. So there is a stain which is now on the other side in the sort of a AV groove area. And once this wire has been removed, you can see that it sort of drains in a space there. However, patient was hemodynamically stable. So at this point, now what we did was we utilized the occluded vein graft, which has been there, and we said we're going to come through the occluded vein graft and try to see if we can get into the RPDA. As you can see, there's a turnpike there. We were able to use a pilot 200 wire to get down to the graft. Once we went down into the distal portion of the graft, the wire kept on going just on the side of the stented area. So it was challenging. Either it will go up or it will go down, and it probably miss the center part of the stent, which is probably more fibrotic area in that stent. So at this point, what we did was we brought in a Suzuki again, and we used a parallel wire technique. One wire is there. The second wire, we actually were able to then hit the center of this and gain more sort of a ground inside the stent. And then we're able to then once we gain some ground in here, we're able to bring in a turnpike and park it over here, and then use a slippery wire, a pilot 200 to get across this and into the RPDA. We had to balloon this area. And after the balloon, as you can see that we are in the true lumen of the RPDA. So at this point, we had spent quite a bit of time trying to open this area. So we decided that we are, instead of coming and making this a retrograde, antegrade technique, we're just going to stent the vein graft. And we ended up stenting the whole of the vein graft with the 4 stents. And this is the end result of the vein graft. So the patient was back in the lab in a month with now this newly stented vein graft totally occluded. And the area which was sort of a stain has healed. And at this point, looking at this particular right coronary artery, we thought that this may not be the PDA, because what we are seeing is we are seeing the PDA when we do the collateral shot, and when we did the revascularization of this, it was a very different PDA. So this may be another sort of a posterolateral branch and not truly the PDA. So we decided to actually go a retrograde first, and we were able to go through the vein graft. And usually it is very easy to go through the vein graft, which is recently occluded. And we were able to then utilize the jump portion of the vein graft. And through that jump portion of the vein graft, we were then able to come backwards into the distal right coronary artery. And here you can see that we have looped in there. Then we use the antegrade dissection to re-enter. And that just didn't help us out. We were not able to re-enter. And as you can see, the antegrade wire is most likely in that same branch that we actually initially went in. We tried to do both antegrade and retrograde dissection re-entry. We were not able to connect. At that point, what we did was we actually injected through the right coronary artery as well as through the vein graft, the turnpike parked into the posterolateral branch. And we could see that where we have created an dissection, and there is a connection between the antegrade as well as retrograde area. And at this point, we were able to just come up with a pilot 50 wire, and were able to easily cross over and then bring the wire into that vein graft and park it there. And then we landed up putting stents in there, and you can see the end result is that we were able to open the right coronary artery, and the PDA is still revascularized through the jump portion of the vein graft. So to conclude my talk, now graft failure is common in elderly, and I think it's very important to be familiar with the multiple tools and techniques to do a complex PCI, which is required frequently for a native vessel revascularization of these particular patients. Thank you.
Thank you very much, Dr. Sachdev. I think that was a fantastic presentation that you have had on graft failure in the elderly patients. I think this highlights a very common clinical problem that is that we are seeing more and more in elderly patients here in the United States, where patients have had bypass surgery at maybe when they are 60, 55, 60 years old, and then as they get older into their 70s and 80s, they have graft failure, and now we have to deal with the native vessels which have been closed and have had accelerated atherosclerosis. Now, how big a problem is this in Vietnam, where you see cases like this? Maybe Professor Quang, you can tell us.
Thank for your asking. So basically, we also see the same situation. However, in Vietnam, a little bit different because normally patients prefer the PCI rather than cabbage. So that's why we don't have very much care of the cabbage. Second thing is usually in our southern area, they not 100% using the both radial or arterial condyle. So that's why a quite high prevalence of the vein grafts on the cabbage patient. And usually after the 5 years, the vein graft is occluded. And for the PCI, for the vein graft, the outcome is also worse. So that's why usually if the patient come back with the graft failure, usually we try to open the native vessel, similar like Dr. Rajesh showed the case. And if we got some patent, not 100%, but still got a flow, then we use the vein graft as a marker or as a pathway to open the CTO of the native vessel. So this is the way we did. And the problem is if the patient got a native graft failure, it means that you already got a negative remodeling of a native vessel. So that's why somehow you cannot put a very big stent. So in some aspect, that's why we try to do as much PCI as possible. Because if you started with the cabbage, then the vessel becomes smaller and smaller over time. And later on, we have no chance to put a big side of the stent for the patient. So this is something like from our own experience and perspective. Thank you.
Thank you very much, Professor Quang. And can I know from you which one of you is doing a lot of CTOs in Vietnam?
I think here Dr. Mu Minh Hung is quite a big guy to do. So a lot of CTO case. You can ask him for further comment.
Okay, I will do that. So Dr. Mu Minh Hung, the question is, you have seen maybe, 2 cases here. How would you approach this case? Would you have gone about it the same way where, we go from a certain point and then at that point, the patient has been on table for 3-4 hours, just put a couple of stents in the vein graft, come back for stage procedure. What do you think about the approach in these cases?
Thank you very much. Actually, I just think the very excellent presentation. I learned a lot from that as well, and I think I do the same way as you already performed for the patients, and I think that some situation I have to stop because stop for a while in order to do the investment procedure and then ask the patient to come back next time. If the patient still stable, and I think investment procedure is the alternative for the long procedure. And sometimes I do some situation the patient cannot tolerate with the long procedure, so we have to do that kind of thing. And I love the first one but I have a question for you because is it retrograde wire to from the vein graft to the ramus? Do you have the turnpike, the U-shape turnpike in order to rewire to the ramus, because you have to use the double lumen catheter? But I think this situation, the angulation is big because from the saving vein to the ramus. So the turnpike with the U-turn at the tip, do you have that one in your cath lab in order to shorten the duration of the procedure? Thank you.
No, we do not have. We have the turnpike. We have the turnpike LP, but I don't think we had attempted it with the regular straight turnpike, but we don't have a turnpike with the U-turn at the tip. Is that something that is special that is available there?
No, not actually not available in Vietnam, but I know that the turnpike devices, they have that kind of device. So that if we have that device, we may shorten the duration of the procedure in this situation, because it's a very interesting case that I think so. And I love that case.
So in this case, we used a supercross, which is also like a 90-degree angle catheter, to sort of probe that area and see whether that will provide the support, and we can push any sort of wire. So we tried with a softer wire, a Fielder XTA.
Yeah.
It didn't work. Then we tried with a slippery wire with a little more weight on it, Pilot 200. It didn't work.
Yeah.
Then we said, okay, we're going to do a heavy duty wire, because we want not only just it's pointing towards there, and so we can maybe push the heavy duty wire, which is Confiance of Pro 12. We were not able to sort of penetrate. And the other thing, what happens is, if you're using all these wires repeatedly, there is a very small channel. So you can just actually occlude that channel also, or you can sort of, disrupt a little bit of that channel, and that can occlude also. So after making several attempts, that we said, okay, well, we have failed. And we even put the balloon in the stented segment also, so that nothing prolapses down. So it gives me a little more support, and then try to push forward. So that didn't work either. I think the problem is when you have a bigger caliber vessel, and the wires are more likely to go into that particular low resistance channel, rather than just trying to track through when you apply the force. And that's exactly what was happening in our particular case. So we actually, after several trials which failed, we learned from this. And then we said, okay, well, the only other option which is left is to come integrate.
Yeah. Thank you. Agree.
Thank you. I think in the interest of time, we will move on to the next speaker. The next speaker is on optimal PCI in elderly patients, imaging or physiology, Dr. Wen Nhok Phang.
Can you see my slide?
Yes, we can see your slide. It is good.
Yeah. So for the next talk, I will say something about the optimal PCI in the elderly patient, imaging or physiology test. So here it is my disclosure. So basically, when we're talking about the optimal PCI for the elderly, is something like remained poorly defined. So you can see here, this is a recommendation for the PCI for the elderly patient based on the latest ACA and HSA guideline for revascularization. You can see here the older patient is a very vulnerable subset of the patient, just because a lot of complex presentation, high prevalence of comorbidities, and also increase a lot of risks of breathing complication and shock after PCI. And one more thing is very important here is adverse interaction between the polypharmacy for the elderly patient, and also a lot of related change in the functional and coronary anatomy. And in reality, we lack a lot of robust evidence for the optimal strategy for PCI. So when we're discussing about the optimal PCI, the first question is come up like, what should we do for the patient, optimal medical treatment first, or a PCI or CABG? So basically, we need to very careful consider of the risks and benefits in accounting with the patient preference and frailties and cognitive status, and also the life expectancy. So the previous speaker, Dr. Huan, already mentioned about the frailties, and Dr. Kumar mentioned about the calcification. So respect the complexity of the decision making for the PCI. So basically, there is a few data showing that for the older patient, they still benefit from revascularization, not only the PCI, but also the cabbage in some same or sometimes is greater extent as a young patient. So this is data from the Canada cohort study in the previous time, showing that you can see here after adjusted for the risks, the survival curve in the age over 70 is actually better if you compare for the revascularization compared for the medical. And also in the latest review for the cabbage treatment for the elderly, you can see here all the data showing that the similar outcome in the older patient as a young patient. So basically that it means that for the coronary artery disease treatment, age is not a control indication. You still go ahead and what you did for the patient is still benefit for them. However, for the elderly patient, you need to put the patient in the centric. So it is something like the consideration in the patient center, informed choice and decision making. You can see here the heart team work together, consider the pre-procedure factor and also the post-procedure factor and peri-procedure factors. And for the elderly patient is a little bit difficulty compared to the young person, because for a young person, a patient still can come back and do the procedure many times later on. But for the older patient, it's different. So that's why usually you need to consider is benefit and risk of the revascularization, risk of the future cardio event, patient value and preference, life expectancy, and also the other thing like frailty, comorbidity, quality of life, functional impairment, and life expectancy. So basically everything you put together, you discuss, and somehow the optimal strategies for patient is doing nothing but optimal medical treatment. So this concept optimal PCI here is different compared to the young patient. I just put one slide to reflect the impact of the frailty of the elderly patient. So it means that the frailty is very common when you do the PCI for the elderly, but the PCI still got a strong survival benefit. So that's why you still go ahead to do for the older patient. Here there is some few practical consider for PCI in the elderly. Consider the techniques, consider the complication, especially the drug before and after the procedure. So when we do the PCI, the concept the optimize, it means that sometimes you need to optimize the tactics for post-PCI. And it is the diagram showing the target you need to optimize post-PCI. So you can see here, you need to reduce the plaque burden, you need to avoid the dissection, no extensive protrusion, try to avoid the extensive malposition. And also you need to have something like a criteria to get the optimal result. For example, like a relative extent expansion more than 80%. So basically it is something like all the criteria to get the optimal stand result based on imaging. So if I back into the first question, like imaging or physiology test, if you really want to get the optimal target, meaning that you need to got some imaging tool to help you to optimize the target. So here we can see this is the intravascular imaging consensus showing that actually the intravascular imaging to guide you to coronary stenting is in very good way. Not only to identify the coronary lesion, but also to guiding you to optimal the stenting. So there is a few concept from that one. The IVERT guided actually is improved the clinical outcome in selected patient, for example, like for long lesion and CTO. And also even in the very limited data from random control trial, but also the OCT guided might be got the same benefit for that. And actually we have a very strong evidence for complex lesion morphology and also in ACS. But less benefit from the simple or more stable lesion. So meaning that the more complex lesion, you got the more benefit from the intravascular imaging. So that's why for the elderly patient, basically you have a lot of benefit from the imaging guided PCI. So the question is, can we use the functional, and can the FFR can optimize the stenting? So here is some summarized showing that a lot of study try to identify whether the FFR can optimize the stenting, and you can see here a lot of study which very different criteria for FFR cutoff. So basically, you can see here if we have FFR post PCI is suboptimal, and then you need to go a little bit further to access the mechanism. Maybe you need to do like identify the secondary lesion by the pullback, or you using the imaging to identify the unclear mechanism. So basically, even the FFR is using there, you still need the imaging to continue further assessment the lesion. And one more thing is important here is somehow the post PCI FFR in some certain is not reliable. For example, if you put a very long and ultra long DS, is very common in Vietnam situation to save the cost. And basically in this situation, because you reduce the compliant vessel, so that's why the FFR post PCI is not really reliable. The second thing is if you have a lot of microvascular damage, for example, like ACS, or you have a scar, and then the post PCI FFR is not reliable. And also that because you have a lot of study and cut off, so that's why sometimes you don't know which way to choose, and that's why the usefulness of the FFR post PCI is reduced. Here is something like you have consider the prognostic implication of FFR after the chronic stenting, and you can see here there is quite a significant relationship between the post PCI FFR with the tachycardic vessel or failure or cardiac death. So actually, you can use FFR to optimize the stenting, but in some case, you still need FFR plus imaging. So that's why, in terms of cost, imaging might be better choice. So when you come back into the comparison between the anatomic and physiology assessment for PCI, you can see here there is some situation you favor anatomics and some situation you favor the physiology assessment. But usually in the elderly patient, when the burden of the plaque is there, a lot of calcification is there, more stable patient and more complex lesion there, imaging is much better. So if you compare directly the anatomies and physiology, what happened? So we just started with the first randomized control trial to compare the FFR versus angiogram for decision-making of PCI. It is a very famous, and also the landmark trial is a FAME. And it is some sub-study try to identify whether it's good in the older patient or not. And you can see here, this is the data compared to the group between the young patient less than 65 and also in the older patient more than 65 years old. And you can see here the result the same. So basically for the older patient, FFR is still benefit compared to the angiogram to choose the patient to get the PCI. So in this situation, FFR is win compared to the angiogram. In the next step, we have another important study compared FFR versus OCT. So this is a FORZA study, and it's in this situation they compared FFR with the OCT, not only to choose the lesion for PCI, but also to optimize the stenting. And you can see here, if we do the OCT, actually the composite endpoint combined MACE and significant angina is better if you use OCT. If you use OCT, you might increase the PCI, you might increase the contrast, but you actually reduce the MACE or significant angina. If you do the FFR to guide the PCI, you're increasing the medical therapy, less kidney injury, and less cost. And if you see the both group, the mean age is something like 70. So basically this can apply for the older patient group. And in this situation, OCT win. So it meaning that the imaging is likely better. And we continue with the latest trial, just announcement in the ACC this year. It is a flavor trial, compares FFR for the IVUS for guiding decision-making of PCI. It is a two group. One group is using the FFR and one group is using the IVUS. And here is not only choose the lesion for the PCI, but also to optimize the PCI based on, for example, for FFR post PCI more than 0.88, or the gradient of FFR is after crossing the stent is less than 0.05. And also for the IVUS, you can see here, try to get the minimum the stent area more than 5.5 millimeters. So it's a very strict criteria to optimize the stenting. And the reason here is, you can see here, even in the group with the medical treatment, or in the group with the FFR and guided or IVUS guided PCI, actually the reason from two groups is the same. And this also is similar between the group less than 65 or more than 65 years old. So the conclusion from the flavor trial study showing that FFR is the same as IVUS to guided the PCI. However, this group is only included the low risk patient, and if the patient got a little bit more high risk with the more complex lesion, likely imaging is better. So this is something like a direct comparison between the anatomy and physiology. And in the realities, one question happened is FFR, is it really corrected or really poor in the elderly? And so we can find some studies showing that FFR might be overestimated in the elderly. So the same stenosis severity with FFR is higher in the older patient compared to the young patient, due to the compliance of the vessel reduced due to the age. So basically, if you try to apply the FFR to identify or optimization the stenting for the elderly patient, sometimes you need to consider like you miss some part of the patient due to the overestimation. So that's why we come up with which guidance modality is better for the PCI. And it is a very important analysis, meta-analysis of more than 28 randomized control and also more than 11,000 patients. So we can see here, they compare all the IVUS, OCT, FFR for the MACE, cardiovascular death, MI, and total vascular vascularization. And you can see here, they compare one by one. And also for the small group like a stroke, stent thrombosis, and because it is also important for the future for the older patient. And the conclusion is, if we do the meta-analysis, the evidence here is very good for the IVUS guided PCI, because if you use IVUS guided PCI, it means that you've got the less MACE, you've got the less cardiovascular death, and also the TVR. So this is something like very important for you to choose. And basically, if we combine the whole thing together, theoretically, and also the data, it meaning to me that might be the imaging is very good for the PCI. And also one thing is really important is IVUS might reduce morbidity burden post-PCI. For example, like you have a very important study like a MOSA-1, showing that if you use IVUS, you can reduce the contrast use, and then you can reduce the kidney injury after the PCI. It's very important for the older patient. And also, if you use imaging to guide you to optimize the stenting in the future, you can shortening the DAPT. So we're just waiting for the trial. This one is IVUS, ACS, and anti-MACE DAPT trial. It will be completed is next 2 years, and then we have to answer that, is it possible if you optimize the stenting and then you can reduce the JPT. So this is come into my conclusion. So basically, when you're discussing about the PCI optimization in the elderly, you need to calculate for the patient preference, severity, complexity of the lesion, concurrent morbidity, and also the interacting between the polypharmacy and age-related change. The second thing is really important is the older patient is benefit from the PCI, similar or some extent is greater than the young patient. And also the outcome for optimization is not only the directed related to the vessel, but also to the relevant outcome for the future remain life cost for the patient. For example, like the acute kidney disease, bleeding later on, because this is really important for the older patient. And so far, the imaging or physiology tests are very useful to guide it to make the decision. But for either physiology or anatomical assessment has own advantage or disadvantage. So far, for the older patient with a very complex lesion, I think that the intracoronary imaging, especially the IVUS, is likely the appropriate guidance modality for optimization PCI in the elderly. However, we really do need more robust evidence for the future decision making. And this is my talk, and thank you very much for your attention.
That was an excellent talk, Dr. Kwang. So question I want to ask the panelists and Dr. Kwang is that in your present practice, how often you actually do IVUS and how often you do FFR? And for the stent optimization, how often you are actually using FFR as a modality?
Yeah, I think there is two important question here is to identify the suitable lesion or appropriate lesion to do the PCI. And second point is how to optimize this one. So for the first part, frankly, have to say that we usually the prevalence of the IVUS or FFR in our cath lab is less than 20%. Because we don't have the fully reimbursement for invert and for IVUS and FFR. So that's why we base a few things together, combine together to decide which lesion need to do. Second point is how to optimize the result after the PCI. So I think that the experience from the IVUS patient showing that you need to do the very carefully post-dilatation. So basically, if we have a case with a simple lesion, we just go ahead, continue with the post-dilatation is very aggressive, and we finish that one. But if we have a complex lesion, for example, like bifurcation, calcification, and then we try to use IVUS. And nowadays, we recognize that the important to use IVUS to optimize, especially for the older patient. Because for the older patient, sometimes you just need to fix a one single tandem lesion rather than a very long lesion. And also you need to protect as much branch as possible. So that's why the imaging guided PCI is really important because can give you an overview and also to identify the risks and benefit for that one. So to your question, to choose the lesion, we don't use very much IVUS or FFR. To optimize this, to optimize the stenting, we favor using the IVUS for the complex lesion. Thank you.
Okay. Thank you so much, Dr. Kwang. Dr. Kumar, what your thoughts are in US practice? How do you actually optimize your stents in US and how often you are actually using FFR post-PCI to optimize the stent?
That's a great question. So I think the issue really comes down to what are you looking at in terms of the word optimize. The word optimize is a somewhat nebulous term, and I think that's what we need to look at. So I think Professor Kwang showed a very beautiful slide, which actually showed the stent and all the things that can go wrong with the stent. You know, whether you can have a dissection, either proximal to the stent or distal to the stent. Is the stent adequately expanded? Is there plaque prolapse in the stent? You know, have you achieved the MSA of 5.5? If this is a significant proximal vessel. So those are the questions. And some of those questions can only be answered with imaging, whether it is IVUS or whether it is OCT. Now, whether the flow in the vessel has been tackled, whether you have stented the vessel adequately, whether your stent is long enough to cover all the pressure drop in that vessel, that can be achieved with you know, FFR or in the more contemporary era with a diastolic pressure ratio as well. But that doesn't tell you what is actually going on to the stent itself. And indeed, if you look at the defined PCI trial, where about 25% of patients left the cath lab with the abnormal post-PCI IFR, 1/3 of these were distal to the stent, 1/3 was in the stented segment, and 1/3 was proximal to the stented segment. So, that actually tells you that you can have problems that happen in all of these locations. And in a dream ideal world, we will just forget reality for 1 second and go to a dream world. You would like to have both methods to be able to assess this. But I recognize that, we do not live in this dream world all the time.
Excellent. Thank you. Thank you so much. I think it's the diffuseness of disease. If you're dealing with a diffuse disease in a diabetic patient, it will be extremely hard to actually achieve a FFR of 0.95 or even 90. On the other hand, if you had a focal lesion and that you stented, that if you actually do a post PCI FFR and it's greater than 0.95, you have optimized it. But the best way to optimize your stent is just to look with that intravascular ultrasound, because there are other things which are responsible, as you alluded to. And then one more important thing is the spasm, which happens especially after a complex lesion, which is stented, and after so much of manipulation, the artery with the rota and all that stuff. It can also affect your FFR, especially in patients with atherectomy. You have distal embolization. If you're treating the patient with ACS, there is distal embolization of a clot, which can affect your FFR, but necessarily does not mean that you have optimized the stent. Okay, thank you so much. In the interest of time, I would actually move on forward, and I would like to actually invite the next speaker. It is my great pleasure to invite Dr. Tak Nguyen to give the next talk. He's going to talk about metamorphosis of coronary flow dynamics in the elderly patients, concept of fast or slow growth lesions, and selection for PCI or medical treatment. Dr. Nguyen. Dr. Nguyen, you got to unmute yourself. You're still muted.
Okay. How about my slide? Is it full screen?
Not just so far.
Not full screen.
Okay, okay.
Yeah.
Now full screen, yes.
Yeah, thank you. First, thank you for I listened to the presentation, and we have very good information. So the problem we have, it is in the last the outline of my talk. So in the last number, question 3, which lesion is significant? Gautam mentioned that we have to use the physiology And then Raja suggests that we have to use imaging. And Dr. Kwang mentioned that about the reality and the cost effectiveness of devices. So in my case, I show more about my current research about this problem. So the first question I have is, how do we know which patient can have low risk of instant restenosis because it has good flow, a good IFR? And number two, it is now we have lesion before PCI, and we have to say how we know this lesion is severe enough to require PCI. And in general, for the elderly patient, I agree with one of the speakers before. If my patient, even they are 80 years old, but they are physically fit, good blood pressure control, great LDL control, then they have very good coronary arteries, even they are old. But for the patient above 90 years old, then I have a problem, because at that time they have slow flow, they have thick peripheral layers. For the question number two in my talk, I don't discuss much because everybody clear that in elderly patient with calcified lesion arteries, it's difficult to advance wire, balloon, or stent, or to deploy the stent. And then we have to use different technique, atherectomy or IVL. But my focus is which lesion is significant? How do we know? Now we don't have, not every hospital in Vietnam or Asia, not every hospital has IVUS or IFR. So how do we solve that problem? And remember that at the beginning, all the times the technique is difficult and complex, but slowly it becomes simplified, easier to be used. So that's and all the time in my research, I mentioned about laminar flow or turbulent flow, especially we talk in front of a professor of engineering. So here is the same picture before I used to show. Here the patient before stenting. We look at the white arrow. Here we have the artery full contrast. And then we continue to record the picture. And we see the blood coming in and going. See in C here we have the blood in white color coming in. And in D, it arrived to the lesion. And in E, it passed the lesion. And we see the turbulence at the mid segment with the red arrow. And after that, we put the stent. And now we see again in B, we have the flow coming in. And in C, we have laminar flow now. No turbulent flow, and we have no reverse flow. Another part is the speed of the flow is faster. If the speed is faster, then the pressure is lower. If the pressure is lower, then the ratio to calculate the FFR is better, improving above 1. If the pressure proximal is higher than the pressure distal pressure, then the ratio is 1. We don't have to use the IFR, but we can calculate that the IFR is above 1. So this is, I used to talk about that. And we presented in formal abstract and preparing the paper to write a paper and publish. Now, I show another case. I really love this case because the patient had a lesion at the ostial LAD. My current question is why the patient developed lesion in the ostial LAD. But in this case, we put a stent, and we see the year later, here in the picture 2 here, a year later, 2 years later, we see the flow is laminar and the lesion is wide open. So if we can have laminar flow after stenting, I'm doing research about that now, accumulated patient. If we have laminar flow after stenting, we can prevent in-central stenosis. So this is what we did before and we discussed many times. Now, what about what new today? Here it is, I have a patient. This is a very nice patient of mine. I put the stent in the LAD and we plan to put the stent in this lesion in the distal RCA, but the patient refused because the patient is stable. And it was 10 years ago. And now the patient feels stable, no acute MI. And I keep asking why this lesion did not progress to become more severe or or develop acute MI. And like you know that when we do research, not all the time patient agree to have the second angio. So but I still follow up the patient. The patient did very well. And so then case 1. Now case 2. Here is, we have a patient with severe lesion in the right coronary artery. We put a stent. After we put the stent in the mid RCA, and now we discover the patient had a lesion in the distal PDA. But the patient is stable, working normally, can do strenuous work. And so the question is, why this lesion does not progress to become more severe, the distal lesion, and why the patient did not have chest pain. One of the explanations from my part is the patient, the right coronary artery, we have reverse flow from the left ventricle to the coronary arteries. So the distal part of this lesion is well vascular, well supplied. There's no lack of blood in this area. Now we case number 3. Here it is. This patient is an elderly patient, and if we look at the lesion here compared with the proximal segment, it is more than 50%. And this patient is the son is a lawyer, and he had his billboard advertised in my area. So we see the name of this patient on the street. So it's a very nice case, and the patient refused angiogram for many years. Now the patient needs surgery, and I have to do it. I have to do a stress test and do an angiogram, and we have a lesion like this. Is this lesion significant? You can put but looking at it only, it's not too severe. But if we compare by using the diameter of this lesion, this segment, compared with the proximal segment, it's very severe. But the patient had laminar flow. So I cleared the patient for surgery. She did very well. I was so happy with the case. Now, the next one, here we have a lesion here. This one is not too severe. But if you compare this lesion with the proximal segment, it's quite severe. So the question is it significant? Do we have to put an FFR? Or do we have to put an IVUS? So I follow up. So I use the laminar flow. Now look at, okay, now this one more case. Here it is. This patient had severe lesion at the ostium of the LAD. I did an FFR negative. So we didn't have to do it, to fix it. But the question is why? Why the lesion does not develop further? Okay, so let's go. Okay, so this one, so in the first picture here, it is the picture I showed before. And this one, it is 2015. And here we have, clearly, he had laminar flow. He It does not have turbulent flow to irritate the plaque at the lesion. 2 years later, we did again. The lesion did not progress to a more severe degree. And the patient is stable until now, 5 years later. No complaint. So I see that, I learned from this case. I use laminar flow to determine whether or not a lesion is stable or unstable, or is a patient can become severe or not. If the patient, now like the next one. So here, this is a patient we talked before, and he had a lesion here. And if this lesion, if you compare with this proximal segment, it's quite severe. So I show now, they show the picture of we see the flow coming in. We see the laminar flow here, very fast. And no reverse flow to irritate the plaque. And the patient did very well for the last 1 year. We follow up. Now, here's the case before. Now, this is the case of the elderly man who refused the angio. And here's the lesion. And why I feel so confident to send the patient to have major surgery. We have to control the blood pressure well. We have to control the cholesterol level well. And now look at the flow. See, we see here. Next one is here. Next one is here. Next one is here. We have laminar flow. No reverse flow. So there is no reason, there's no mechanism to irritate the plaque and to cause it to become more severe or to break the cover. So now, in this one is a reverse. Here we have a patient had a lesion here, had no lesion here, and 3 months later, in the left side, you see the lesion. So what happened to here? So I look back at the chart, look at the film back again, the film. He had turbulent flow here. So I don't have many cases like this yet, just only 3. That means we have to have a patient with clean lesion, clean artery, and develop lesion in the matter of a few months. And what I saw it is the patient had turbulent flow there. So in conclusion, what happened and what the weakness in this theory, this hypothesis is, if you put a wire, you change the configuration of the arteries, you make the flow faster, just with a wire. Then after that, you put a stent, sure, you make the flow faster. So now what happened if you expand the stent and you did not expand the stent optimally? You can make the flow better. I did quite a few times. Every time that we have a wire, a balloon, then a stent undeployed, and the deployed stent. And I have problem with bifurcation, osteolesion, how to explain with the flow. And in summary, in my part, at my research at this moment, in the last 1 year, we present this kind of information at SCI, at TCT, at the ACC, and ESC. And so the number 1, the laminar flow after the stenting, one day, hopefully, can replace IFR or IVUS in simple cases. I don't say that in complex cases. Number 1, here clearly we have laminar flow in osteolesion. And this one, it is 3 years already. I'm so happy. The patient is happy too. Number 3, and here it is, very clear case. Anytime I can do an IFR, I do. The reason because I want to compare the laminar flow, turbulent flow, and IFR. In this case, I did. And clearly, the flow is laminar. The last question, last one. Now, we have, all of us agree that angiographic image cannot say everything. So in a 50%, 60%, 70% cases, a lesion, if we have laminar flow, I say that I feel very confident that we clear the patient, and we don't have to do anything, we don't have to put a stent, and we have to control the blood pressure very well and control the LDL very well. And it prevents the progression of the disease. And I show the picture of the reverse, no lesion, becomes severe lesion with turbulent flow. And thank you very much.
Thank you so much for excellent presentation from Professor Thạch Nguyễn. I think it's very interesting. Today, you try to print the theory, the mechanism, the finding in your theory about fluid dynamics in here, blood flow, to compare with the angiogram, with IVERT, with the FFR, IFR to do some explanation, interpretation to predict the lesion, significant lesion and non-significant lesion. I think we should continue to do more data to if we can perform some study and try and to prove for this the finding is it's wonderful and very excellent. So I like to hear some comments, some questions from panelists. First, I would like to invite Dr. Rajesh Sativa.
So my question is, Dr. Ben, this was an excellent presentation, and the picture qualities you have done, they're phenomenal of those arteries. Now, in this day and age where the radiation dose is also monitored, how do you sort of put that in the context of understanding laminar flow with the angiography? And I'm sure these are probably either a 15 frame or a 30 frame pictures.
It is 30 frames per second, and there are only a few views that can show the best. Let's say, for example, the right coronary artery, the best view to show the proximal lesion, it is the LAO caudal view. And for the right coronary artery, I'm very interested in the distal flow, because this is where we have a reverse flow, and we have, and I show the picture of cavitation. That means in the right coronary artery. So the LAO cranial view shows the best. So when we see that, we only, I agree with you, I understand the question. We take the picture, long, we take a lot of pictures in this view, not every view. Now, what about the LAD? The LAD can show best the flow from the left main to the distal. It is the LAO cranial view. But if you have to raise the pressure up, to raise the circumflex up, so we can have the good flow from left main to distal LAD, it is RAO cranial view. So if we see that, when we don't take a picture, long picture for every view, let's say, for example, the spider view for left system is worthless if to look for the flow. You see, because the foreshortening of the distal and mid LAD. So I understand the question, and we try to. We have to try to avoid the radiation to the patient and the physician. And we focus on a few view only. We can show us the best, the flow. And then after that, we cannot view online. The reason because we don't see everything. Cavitation is the rupture of the bubble in the pipe. It's very difficult to prove it in coronary arteries, but we could in the right coronary artery, in the distal one. So it takes time, and so I only take long take a lot of pictures in a few views to prevent exposure of radiation to the patient. Thank you.
Okay, thank you. And one more opinion or comment from Dr. Kumar.
Yes, Tak, that is a beautiful presentation with very nice high resolution images. Now, I think the very interesting thing is to look at the correlation that you have done with some of your work with the IFR or FFR or anything like that. But as you have highlighted, that does, having the wire there itself does affect the flow. Yeah. So then the question for you is, have you compared with one of the angio FFR things?
I know the technique, but I didn't do it. I didn't compare yet with the angio FFR, but I know that it's similar concept and similar concept and similar study. So I understand.
Because that may be very easy study to be done, because you can look at some of the cases you already have and have them to do the angio FFR even offline, and you can compare.
Yes.
Yeah.
Okay, thank you. One more comment, opinion from the Vietnam panelists.
Thank you for amazing presentation about the laminar and turbulent flow. So I have the same opinion to the good time. We in our CAT lab we do some VFFR. It means that we can measure the FFR by the chest angio. So we have to do the 6 friends because 5 friends catheter cannot fully evaluate the coronary artery, and we have to choose the two views, at least 2 views, different views to see the flow and to measure the VFFR. So maybe sometimes we have to use the machine contrast, not the contrast by the operator hand to see the flow. So I have a question for Professor Thật Nguyễn that if we want to standardize the two lamina, should we use a big catheter contrast by machine because the machine is more stable with the pressure and something like that for your procedure? Thank you.
Usually, there are 2 very interesting questions. Thank you. So usually I use 5 French because the diagnostic we use 5 French. But if the artery is so big, because let's say the patient had the big man, then we have to use 6 French. So for the flow, so we can fully fill up the artery with contrast. So we have, and sometimes I use 6 French, especially in patients with severe heart failure. Severe hypertension. Because the severe hypertension, because I just saw one case, very interesting, the blood pressure above 200, and the patient had reverse flow from left ventricular contraction. And if we use 5 French, we don't see the flow. We cannot fill up the artery with contrast. So I use 6 French in that case. Now, the second one, it was the flow. as long as you can fill up the arteries with contrast, then after you fill up, you see that you fill up the artery with contrast, then you stop injecting and you see the flow coming in. So there's no question about the flow, because the flow is after injection. You inject in and you see the contrast fully visualize the arteries, and you stop injection. At that time, you see the flow coming in. The flow coming in, and this is what you do. So there's nothing to do with we have to use machine injection, or we use hand injection. Everything is okay as long as the arteries is completely filled with contrast. And I use the catheter in and the catheter out. Without the catheter, let's say we inject and we remove the catheter. What happened? It doesn't work. We leave the catheter there. We will see very beautiful. Thank you very much.
Okay, thank you so much. I think they still have many questions or some suggestions for Dr. Thạch Nguyễn. And I hope in the near future, we have some data how to get the relationship or correlation between the FMR, IFR, and your flow, reverse laminar turbulent flow. Yeah, thank you so much. And by now,
One question only. Can I ask Dr. Wu, because I understand you do a lot of IFR. The lab can help them. Thank you very much.
Yeah, this is my honor to be we have the
protocol.
penetration of protocol for that. So
thank you.
Yeah.
Okay, if I left behind, we move to the last but not the least, Dr. Ngô Minh Hùng. We are sorry a little bit later, Dr. Ngô Minh Hùng, with CTO PCI in octogenarian should or not should do.
Yes, thank you very much for the introduction. Can you see my slides?
Yes, we can see.
Yeah, thank you very much. And good evening, my colleagues from the US, and good morning, I think at lunchtime already, faculty from Vietnam, and audience on the online. I bring here the case that the 86-year-old gentleman with the cardiovascular risk factor, the hypertension, dyslipidemia, CKD stage 3B, and with the peripheral artery disease as well. And EKG shows that normal sinus rhythm at the fresh globally, and at the elevation at the elevated at the AVR ejection fraction 30%. Comorbidity and is the hypertension, peripheral disease, and CKD as I presented. And currently the patient diagnosed non-STEMI and hypertension, dyslipidemia, and this is the EKG. You can see that at the elevation at the AV1 and AVR and refreshed globally. So this is the angio. The patient indicated for angio, and to see where the what can we do for the patient. So this is the left side, and the right side the CDO, and the circumplex also have the significant lesion. The proximal LED also have significant lesion, and at the bifurcation after the diagonal one. So that you can see here the angulated LED and the CDO on the right side. So according to this patient, so we asked the surgeon in order to do some like a less invasive operation for the patient. However, the surgeon refused to perform that kind of procedure. So the patient still have the ongoing chest pain. So back to the data from the international data, so we can see that octogenarian have the also have the indication for intervention. However, the percentage of this group is about 33%. Yes. So in that we have about 7% of patients have the CDO with the group of patients more than 80 years of age. So recently we have quite a lot of data increasing the studying about the CDO on the elderly. I really don't know why the data is coming increasing, and I think that nowadays a lot of operator can do the CDO intervention and less surgery for the patient. So maybe the study coming is increasing. So look at the data again. So with the elderly more than 80 years of age, so we see that with one vessel they perform around 75%. Two vessel is 20%, and three vessel is only 5%. So compared with the younger group. So with the CDO is only 10% when we look at the data, only 10% have the CDO perform on the patient with the patient that have the more than 80 years of age. So it's my personal data in general hospital. So CDO PCI for octogenarian is in my experience 8.79%. So the longevity of Vietnamese, as I just checked the internet and the statistic in Vietnam said 73 years. So we still have some patients more than 80 years of age coming admitted into the hospital with the acute coronary syndrome. So the indication for CDO PCI for octogenarian is the guideline from the US. So we have class 2B, 2B level of evidence B for the CDO intervention if the patient still have symptoms. So we do the intervention for this kind of group in order to improve the symptom. So far today the data coming from all over the world. So we see that with the European guidelines, so the 2A class B, and with the US guideline 2B class B. So anyway, we still have the indication for the intervention, and especially with the octogenarian. So this is maybe the latest paper published in the European journal. So we can see that if we do the right CDO intervention, we can improve the symptom for the patient, and even we can do we can lower the incidence of the ventricular arrhythmia, improve the left ventricular function, and even we can protect again the future ischemic event that we call the double jeopardy. So this is the protocol that I also use this protocol in order to tackle the CDO, because if we use a lot of time and effort in order to open the CDO without any benefits, that's not good for the patient and for the surgeon, for the interventionist as well. So when we look at the CDO, we look at the history of myocardial infarction, the QA or echo one motion abnormality or not. So if yes, so we have to use another test in order to see that the viability is still okay or not. If the myocardium is viable, so we send the patient to do the CDO. On the contrary, if the patient don't have the myocardial infarction before QA or echo abnormality, so we ask the patient with the symptom, and if the symptom is yes, so we proceed to do the intervention. Anyways, the intervention are always indications are always important and define the potential patient benefit. However, complication offset this potential benefit. So when we can modify the risk benefits calculus by avoiding or knowing how to treat complication, and thereby getting better. So risk and outcome of CDO PCI for octogenarians. This is the progress CDO perforation score. So actually, when we do the intervention, CDO intervention, so we pay much attention on the perforation compared with other complication, cardiac complication and ex-cardiac complication. So this perforation usually brings a lot of risk for the patient if this happens. So we can see that this patient had the 86 years old gentleman. We use the anti-grade, and we this is the very severe calcify and blunt stomach well. Very quite high risk for perforation. We know that, but so far we don't have the IVL. So what should we do for this patient? So compared with the younger group, the older the group with the age more than 80 years of age, so we see that the mortality, the bleeding, and the MACEs is always higher than the younger group. So back to my case. So should we do the revascularization for the patient? I think the patient have the symptoms, so I think all of you agree with me that we have to do the intervention for the patient. But what kind of intervention? We do the PCI, or we send the patient to the surgeon in order to perform the bypass surgery. However, the surgeon already refused, so we have to do the PCI for the patient. So I stop here for a while in order to ask you that I would like to ask Dr. Rajek that should you open the left or the right side first? Dr. Rajek? Anyway, look at that picture again.
I think
you can continue.
There seems to be on the angiogram you played in the right coronary artery. I saw there was a trickle, there was probably a microchannel. So I can go for the right coronary artery and open it, and then come back and open the LAD circumflex, and that would be a bifurcation lesion. So I would, it's a bigger procedure, and I will use a mechanical support when I do the bifurcation lesion in the LAD circumflex, because that does involve ostium of both arteries.
Yes, thank you very much for that. But actually, the patient had the peripheral artery disease with the pulse on both sides very weak, and the patient had the collocation as well. So the frailty score quite high, maybe 6 point. So the cardiac support, mechanical cardiac support, I thought about that, but we cannot poke the femoral artery in order to put the IBB in. So I agree with you that we go from the right side because it's less the risk than we go from the left. So we started to do the CTO BCI from the right side, and sorry, we don't know why it's not.
We have also utilized subclavian, axillary approach, left axillary approach for putting impellers also.
Yeah, we don't have the we don't have the impeller in Vietnam. So in Vietnam, if we use the mechanical support, so we use the IBB. But this patient, we check the femoral artery, so the pulse there is not strong enough, and the patient had the history of claudication as well. So we stay away from that. So back to my case, so I do the right, I do the intervention for the right coronary artery, and it's not very difficult to cross the lesion with the Gaia the second, and then we open the right side with the after crossing the CDO lesion, we attend to the run-through wire, and we do the ballooning for this. After stenting, you can see that this contrast stenting at this curve proximal to mid RCA. So I think that I will stop there for a while, but you look at this, I do the ballooning in order to stop the contrast stenting, and however this is the CDO, but when we open it, the blood pressure, when we use the ballooning in order to stop the bleeding to the pericardium, so blood pressure coming down like this. So echo chest pericardial effusion, but without any signs of temporal neck. However, the patient blood pressure is coming down when we use the balloon in order to inflation balloon with long inflation. So the contrast standing is stopped after we use the cover stand. Just to stop when we use the cover stand, and the patient stable. So I present this case in order to say that age remains the independent risk factor for worse mortality, major bleeding, and measles in chip. Octogenarian is usually not a candidate for CABG. Hence, complete or incomplete PCI is a possible alternative solution for this group. CPO is not rare in octogenarian, and PCI for this group is usually a high-risk procedure. Therefore, we have to select suitable lesion, suitable patient, and pay special attention during doing the PCI procedure. Even when we cross the CTO, we do the ballooning, we put the standing, and we do the post dilatation, and we get the perforation after we do after the post standing dilatation. So anyway, the patient get better after we open the right side, and the left side we have already protected by the right side, so the patient symptom improve very quick after the procedure. So the left side we already planned for the patient. Anyway, the patient had the good get better symptom after the open the right side. So this is my presentation. Thank you very much for your attention.
Okay, thank you so much. Yes, please go ahead.
Yeah, thank you. Thank you, Dr. Ngô Minh Hùng, for amazing presentation about one very complex case. This is the case that very old patient will have the CTO, and will have the Lehmann disease, and also have the heavy calcified lesion. So in this case, I would like to ask Dr. Gutam, this case, should we do the imaging for the patient after we cross the lesion in the RCA, or you have the other choice for this patient?
Yeah, I think this is a difficult case that has been very nicely done and very nicely demonstrated by Dr. Ngô Minh Hùng. You know, the difficult part about this case is that I think even if you do the intravascular ultrasound after you cross, it will show that, oh yeah, there is some dissection, maybe you have re-entered, everything looks okay. The problem with this kind of case is sometimes there may be calcium that is in the vessel wall that can be actually pushed out of the vessel during post dilation with the stent, and that is something that you might not be able to predict based on your initial findings. So that makes it complicated, and you know, it's not entirely straightforward that you can cross these vessels and prevent these kind of results. You just have to be able to deal with them when they happen, because I'm not sure doing an IVUS after you balloon it and cross it, although we routinely do that, but I'm not sure that that could have prevented this.
Yeah, thank you, Gutam. And Professor Dũng, do you have any question for this presentation from Dr. Hùng?
I have no question because today there are 3 Vietnamese experts in Cyto PCI still here. Dr. Ngô Minh Hùng, you have a long time to Cyto PCI, and you have lots of experience and some data from Chợ Hospital. Dr. Vũ Hồng Vũ, you have just finished one thesis about Cyto PCI, and I think you still have a lot of the data and you have a lot of experience. Look like Dr. Ngô Minh Hùng and another Vietnamese expert, Dr. Nguyễn Ngọc Quang, could stay today here. So I have no question. But I think Dr. Rajesh Settiva, your presentation about repeat revascularization in the vein graft, but I think the content very, very near to the CTO PCI. So I like to hear some comment and some expert from Dr. Nguyễn Ngọc Quang.
I think, thank you for your question. So basically, I think Dr. Ngô Minh Hưng already presented a very excellent presentation about what should we do with the CTO for the older patient. I just want to back in one comment from my presentation. Usually, we need to think a little bit further for the future comorbidities. For example, like a bleeding after the PCI, because it is a really impact for the future outcome for the patient. And also, the more you do with the PCI, then the more you do with the drug, and then a lot of future interaction. So I think that we need to balance all of that. And if the symptom is not very severe, and then I might be happy with the optimal medical treatment rather than try to open the CTO. But if the symptom is severe, then I will try my best to open by all the thing where all the faculty present today. So we will open the vessel. And another point is important is how to choose the complete lesion when we got a very complex. And somehow you need to, like accept that you just open the simple one, simple lesion, try to provide as much blood as you can to the myocardial bridging for a myocardiogram, and then we wait for a while. If the symptom is improved, then you can stop. Because the try, as Professor Zung said, that keep it simple. Thank you.
Thank you very much for the contribution to my presentation as well. So actually, I just bring this case because on the left side, actually, I stay away from that because when we cannot use the mechanical cardiac support with the ejection fraction 30%. And if we have the slow flow or something like that, so the patient collapse on the table. So that's the reason why I do the CTO PCI for the right side with the idea that just get the some flow to protect the left side before I dealing with that lesion. However, the complication is the perforation. Thank you, Dr. Kumar, mentioning about the imaging in this situation. Actually, we look at clearly at the image. The calcium is very deep outside from the vessel wall. So when we try to optimize the stand-up position, so that happened. Before that, the vessel is okay. So actually, I really waiting for the IVL to come to my country in order to maybe stay away from that kind of complication. Actually, what do you think about that, Dr. Kumar? Because maybe we use that kind of device in order to, yeah.
Sorry, but please go ahead.
Yeah. Just they asking you about your idea that we can stay away. We can stay away from that kind of complication if we use the IVL in this situation, because it is very deep calcified outside the lesion. Yeah.
I actually think you may not be able to stay away from this kind of problem. Why?
Yeah.
Because the IVL actually fractures the deep calcium as well.
Yeah.
And I don't have an experience with the IVL perforation, but I have experience with orbital atherectomy perforation. And I will tell you that story.
Yeah.
So it was a right coronary artery. There is a calcified lesion here, and then there is calcified lesion in the distal RCA. So I did one run in the proximal RCA. Everything is good. I went to the distal RCA, did 3 runs.
Yeah.
So what happened is it caused a small dissection that then went into the media and you can actually see because it fractured the medial calcium as well. You can see the contrast then flowing in the media back and perforates in the mid RCA, which we never touched with the atherectomy. So this mechanism where you can have fracturing of the medial calcium and consequent perforation is something that you cannot, that can happen potentially with IVL as well. And you will not be able to prevent this. You will not be able to prevent this kind of complication with the usage of IVL. The only thing that may be able to prevent it is less aggressive post-dilatation or less aggressive treatment. But if you do that, then you will not get a good stent result. So it is a balance, you know, it is a very difficult balance. In the Americans have a saying, you know, you're damned if you do and you're damned if you don't. And that's the problem here.
Yes, thank you very much.
Yeah, see, the other thing is also when you cross a CTO, so if you're close to the, let's say you went subintimal and you were close to the pericardium and you had a chunk of calcium sitting on the other side because you could not just pass through that calcified area and you just went above subintimal and crossed close to the pericardium. And when you try to now balloon and stent and then post-dilate, that calcium is not going to yield, and what lands up happening is you'll end up tearing up the vessel on the opposite end of it. I think this is not something which you can sort of restrict it. So it's an unavoidable sort of a thing which can happen. The only thing is you have to be prepared to deal with this when it happens. That means you can prolong balloon inflation, reversing heparin, and then a covered stent.
Yeah, thank you very much. Actually, this is the CDO. What I put the balloon there in order to get the inflation for 3 minutes, but the blood pressure coming down because they maybe the supply for the right side, from the right side to the left side. So I put the balloon there with the hope that the keep stop bleeding. However, it didn't work because the blood pressure coming down. So we have to quickly switch to the cover stent. So cover stent is shielding the bleeding quite well. So the patient is okay after that without any the consequence, and the discharge right after 3 days after procedure. Yeah.
So if you are still daring to do the left side, there is another option. I know you have significant peripheral vascular disease. We used to put in axillary balloon pump to do these cases as well. So that remains an option.
Yes.
To do this case if you need to.
Yeah, thank you very much. That very excellent idea, but actually not happened in Vietnam yet. I think so. I don't know. Professor Dũng already used that kind of axillary IBB balloon. Yes. And Dr. Vũ, you use the IBB balloon via the axillary artery? Yeah.
Actually, we have the IBBP, but we just put in the abdominal aortic, not in other sides.
So, so I think I will contact Dr. Kumar in order to learn how to perform the IBB via that kind of artery, because now we open the right side already. But if the patient still have the symptom, so I think I bring the patient back and I do the left side with the less left wrist than before that. So I hope that we complete the PCI for this guy.
You are still young, right?
But 86 years old already, so the symptom improved. So I think that it's up to the patient.
Yeah. Wow. Dạ, thầy Dũng chưa có mở micro thầy ơi. Dạ, thầy chưa mở micro. Dạ.
Thank you so much. Thank you for many opinion and discussion from experts. Myself, I still have some question, but by now the time is very late. I think it's near the midnight in America. Thank you, all the faculty of America. So I try to wrap up something in our very interesting virtual meeting. Our virtual meeting is about optimal PCI in elderly patient, and as we know by now, elderly patient account for majority of the patient come in the catalog. And the reason coronary artery disease of the elderly patient often always very complex, complicated, and very difficult to do the PCI. So today we have some many presentations very beneficial for interventional cardiology. The first presentation from Dr. Huang talked about assessment of frailty, and we know the frailty can help us to evaluate the benefits and the risk for interventional care to do in the elderly patient. So we must do the assessment of frailty before we do the PCI. It can give us the prediction of the benefit and the risk of the intervention. And the second presentation from expert Dr. Rajesh Satava about how to manage the very classification coronary artery disease in elderly patient. And as we know, in elderly patient, the coronary artery disease is often very classification, and we need to lesion preparation carefully before we do stenting. We should have a good result. So we learn about some techniques, the rotaplator or intravascular lithotripsy or orbital atherectomy system or the laser. And in Vietnam, we just have only rotaplator. And so we can learn some experience from Dr. Kumar. And the next, my presentation talk about the kit or chip strategy when we do intervention in the elderly patient. And my summarize a simple lesion, we should use a simple way. And the complex lesion, we try to do simple way. But some very complex, complicated lesion, often we use a complicated way successfully. And the next, the presentation from Dr. Frances Satyava about repeat revascularization in graft failure, but your content is nearly to CTO-PCI, because in the America, the patient bypass surgery, I think a lot of the patient, and for a long time. So when the graft failure is CTO in Vietnam, we often repeat revascularization in the instant restenosis. And myself, I have some case with bypass surgery repeat revascularization, but often thrombus or often stenosis, no CTO. So we can learn lots of experience from you. And the next presentation by Dr. Nguyễn Ngọc Quang, how we can optimal PCI on the base of the intravascular imaging of physiology testing. We can hear some of the data, some trying the new intravascular imaging with the physiology. And optimal PCI, we depend on the result after we do the PCI after the stenting. So intravascular imaging can give us lots of the information to do the optimal PCI. I think the physiology test cannot, and so by now we have a lot of the trial, farm, foxtail, flavor, so on, approval for imaging testing better than physiology in optimal PCI. And the next presentation from Dr. Thật Nguyễn. Yes, you continue to build your excellent theory about how to give explanation for atherosclerosis formation in coronary artery disease. Besides the previous theory about atherosclerosis due to LDL cholesterol due to inflammation, you build the theory on the dynamic fluid dynamics, and with laminar flow or turbulent flow, river flow, and today you have some relationship between blood flow with FFR, I think physiology testing. So I hope in the near future you have some data. You can, Dr. Vũ Hồng Vũ can give your data to Dr. Thạch Nguyễn. I think we can have some new discovery. And but the last but not the least, the presentation about the CTO-PCI of Dr. Ngô Minh Hùng in the octogenarian, we can still do with the benefits and of course with the expert, and with very experienced, and we have many interesting and beneficial discussion to help us to understand, to comprehend the problem. And so one more again, thank you so much. First, the US faculty by now, the midnight. And thank you, the panelists and speakers from Vietnam. And thank you all the audience that participation in our meeting. And good night and good appetite for the Vietnam.
Yes, thank you very much.
Thank you, Rajesh. Thank you, Gustam. Thank you, Professor Thạch Nguyễn. Thank you, Professor Dũng.
Bye, everyone.
Goodbye.
Thank you very much.
Thank you.
Nice weekend.
Bye-bye.
Nice
See
weekend.
you again.
Nice afternoon. Thank you. Bye bye.
Yeah, see you again.
Dạ, cảm ơn thầy Hùng, cảm ơn Quang. Dạ.